Evening all. This is Dr. Raghavan from SOGO. My most heartiest welcome to all of you. This is a masterclass on non-muscle invasive bladder cancer. It will be an absolute pleasure and honor on behalf of SOGO and AUO to invite all of you for this meeting. We have excellent international and national faculty, and for another 3 hours, we'll be dwelling a lot on the non-muscle invasive bladder cancer, discussing all the intricacies of the management as well. With that points, I'm going to, on behalf of myself and Dr. Gagan Gautam, the program director for this meeting, I invite Professor Jagdish Kulkarni to give his opening remarks. Sir, please.
Good evening to all, and good morning to the people across overseas. Well, this is our third activity of SOGO. At the conclusion of the last time in early renal cancer, I had promised that we will talk about SOGO at this point of time, and I will tell you what is SOGO means and what are the nitty-gritties. I am here to say that, well, we have a good news. The registrar of the societies has accepted our in principle. However, it is still time. It will take a little more time for us to get to the actual putting into the practice. However, our academic activities continue, and I welcome you to all and enjoy this non-muscle invasive bladder cancer masterclass. Thank you very much.
Thank you, President Sir. I now request Dr. Tushar Aditya Narayan, Assistant Professor of Urology, AIIMS Rishikesh, to take over from here. He is going to moderate the next two sessions, and he will invite all the international faculty to the podium for their talks. Tushar, take over from me, please.
Thank you very much, sir. A very good evening to everyone. I thank Dr. Raghavan and Dr. Gagan Gautam, the program directors for this web symposium, and the Society of Genitourinary Oncologists for giving me this opportunity to moderate this session. The first session was supposed to be moderated by Dr. Ashwin Tamankar, but he had some unavoidable circumstances, so he would not be able to join us. But as they say, the show must go on, so we'll continue with the first session. Our first speaker for the evening is Dr. Stephen B. Williams. He is the Medical Director for High Value Care, UTMB Health System. He is a Professor, Chief, Division of Urology, the Robert Earl Cohn Professor in Urology. He is also the Director of Urologic Oncology, Director of Urologic Research, Co-Director, Surgical Outcomes Research Program at the University of Texas Medical Branch, Galveston, Texas, USA. He'll be talking on risk stratification of non-muscle invasive bladder cancer, the present and the future. Dr. Stephen Williams, you can go ahead with your talk. You can share your screen now.
Okay. Thank you so much for that kind introduction, and it's a pleasure being here today. Let me see here. Get back to where we are. And I think the famous words of 2020, can everyone see my screen? Excellent. So today I'm going to be talking about risk stratification of non-muscle invasive bladder cancer, the present and the future. And even so much as the future is this weekend with ESMO, there are remarkable advances, particularly in bladder cancer, and it's a very exciting time. So thank you very much for allowing me to speak here today. So bladder cancer, as we know, historically presents itself as painless, gross hematuria. And clinical staging always begins with a clinical exam, imaging, and then a meticulous TURBT, of which we'll have excellent presentations here today describing the nuances of this, but also the critical importance for diagnostic as well as therapeutic purposes. In addition, pathologic staging will be discussed, particularly at radical cystectomy, and then the grading. As we all know, it's heterogeneous in reporting at numerous centers, and hopefully we'll be able to elucidate this further here today. Traditionally, the TNM classification system as we present here, and this is the 2017 TNM classification system, presents itself in the standard format, but particularly we're going to be focusing on the upper portion of this slide, the TA, non-muscle invasive CIS or TIS, carcinoma in situ, and then also to T1. And I think what's also critical here is that there are several studies that suggest that the greater depth of invasion with T1 results in a higher progression rate. And moreover, as well, with the grading system, low grade versus high grade also presents a significance in regards to progression rate. There are a few important points. Tumors that occur in the bladder diverticulum cannot be staged as T2. Perivesical lymph nodes are considered regional lymph nodes, and that invasion of the prostate can actually take two forms, either with direct invasion through the bladder and into the prostatic stroma is staged, as a T4A, or intraurethral prostatic stromal or duct invasion is staged as T2 urethral cancer. And this is a pictorial of the staging grading system, as we all are quite familiar with. But particularly at the lower portion of the slide here, we present the two grading systems, of which is 1973, as well as the 2004 classification system. And when we're looking at both of these systems, some centers actually report both, of which also includes my center, because one thing that we're also trying to determine is whether or not these two systems can be grouped together to then give and determine, an actual grading system. And this becomes critically important, particularly with large databases. As such, I'm currently involved with a national veteran affairs database where we have over 11 million patients, over 160,000 bladder cancer cases, that given those heterogeneous reporting systems, we have to coalesce them. And this is one strategy that we are actually applying ourselves. And then, of course, in recent years, the diagnosis and treatment of non-muscle invasive bladder cancer has had a wealth of guidelines. And this occurred more recently in 2016, where we actually now risk stratify patients to low, intermediate, and high risk. And there are various statements that include this. This is one illustration, and this is the AUA guidelines risk stratification system. And then also, too, there's the EAU. And then the International Bladder Cancer Group has also presented itself accordingly. What's critically important, and I'm not going to get too much in depth in regards for TURBTs or cystoscopy, is actually the utility of using blue light cystoscopy, which may aid in particular detection of urothelial carcinoma, particularly CIS. But also, too, inflammation could cause false positives. We have implemented now flexible blue light cystoscopy in our clinic, and even so recently, we're able to diagnose a patient with CIS that may have been unrecognized if they underwent traditional white light cystoscopy. And this is one of the examples of which shows the application of CysView data. And CysView is used in the United States. And when we're looking at these large studies that have been performed, particularly a multi-center trial, there aids in detection of not only urothelial carcinoma, but it also may decrease recurrence rates. In addition, second look TURBT is critically important and is done usually within 2 to 6 weeks after first TURBT. I try to allow at least 4 to 6 weeks for healing to occur and then proceed with a re-TUR. And particularly this is important for an incomplete TUR, large tumors, as well as those high-risk patients. And this is critically important as well because TA tumors, 50% has had residual disease and 15% were upstage. And T1 tumors, there's particularly up to 30% are upstage to muscle invasion. So risk stratification, we now have a particular systems for risk stratifications into low, high, and then intermediate risk. But I think what's also critically is important is to understand the risk of progression. And low risk particularly carries a less than 5% risk of progression, whereas high is a 30% risk of progression. And even in those high risks, it's heterogeneous in the risk of progression with or without CIS. And this has led to risk-adapted non-muscle invasive bladder cancer therapies, where by and large, particularly the low risk, we try to avoid BCG unless they are in fact recur, and then that would put them into an intermediate risk where we traditionally would give 1 year of BCG with maintenance. as well as then high risk up to 3 years BCG induction plus maintenance. However, we also need to consider primary cystectomy for high-grade T1, particularly those that are large tumors, present CIS, LVI, extensive versus focal invasion. And then also we're going to have a wonderful talk today in regards for variant histology. And then we have to consider lastly the location in a diverticulum. So to briefly go over the treatments, a single dose of postoperative chemotherapy has been prior studied, which here is presented by Sylvester et al. And in addition, taking this beyond, the traditional regimens for chemotherapy is a 6-week induction followed by a monthly up to 12 months of a maintenance therapy, or consideration, as we all know, the SWOG trial, as well as the induction and maintenance regimen. And induction and plus maintenance is critical, and not two regimens are alike without that. And this leads to decreased recurrence and progression-free survival when these are in fact implemented together. And this is a wonderful slide by Dr. Kamat in regard to the maintenance regimens, and not all are created equal. And particularly noting that the increased maintenance therapy or administrations further lead to decreased recurrence. This has also brought us, particularly in the United States, for the FDA or Food and Drug Administration, guidelines and more importantly, definitions to follow, particularly for those patients that are BCG unresponsive. And this becomes sometimes quite difficult to those that are not familiar in the field of bladder cancer, and particularly non-muscle invasive bladder cancer. But here are some corresponding definitions that we tend to follow in regard to BCG unresponsiveness. And this is important because TICS is classified as failure to achieve a CR at 6 months, T1 failure to achieve a CR at 3 months, and then relapse of high-grade recurrence within 6 to 12 months of last dose of BCG after a prior CR. And this is put beautifully into this paper by Dr. Kamat in regard to explaining the importance of these definitions in their CR rates, but also to the derivation and then recurrence-free rates accordingly. So what do the guidelines say? Well, if one is BCG unresponsive, strong consideration needs to be radical cystectomy. But what's the reality? Many experts do administer one more round of an intravesical therapy before proceeding with cystectomy, particularly for high-grade TA and CIS. And then also two, although some consider administration, we strongly consider those for radical cystectomy at high-grade T1. And there are various options, which we're going to be going over today in subsequent talks, including repeat BCG. There's a number of wonderful trials that are in fact present. And this is cornerstone to two particular pathways as molecular biology, and we're increasing our knowledge, it almost seems weekly, in regards to understanding this disease, particularly in the non-muscle invasive pathway. And I think what's cornerstone here is the invasive pathway, particularly includes mutations at the P53 and RB1 mutations. And those are the ones that are critically important, and particularly here, this is a classification system performed by a number of well-respected investigators, including Lars Drescott, who has shared this particularly. It's ahead of print, but there's a classification system regarding the mole classification system into 4 particular classes, and particularly 1, 2A, 2B, and 3, where there's a high chromosomal instability and P53 disruption, particularly in the 2A tumors, which present with increased.
I'll direct you to one of your slides wherein you've mentioned the difference in the genetics in the non-muscle invasive and the muscle invasive bladder cancer. So we'll talk a little about the genetics. How do you see the genetic markers being used for risk stratification, the different genetic markers, the mutations in the genes, or the different IHC markers used for the molecular biology of the tumor to risk stratify the tumor? Are you
That's
using this in USA?
Yes. So, and that's an excellent question. I could tell you personally, we're currently investigating this at the high risk non-muscle invasive bladder cancer level because those are the patients that we're critically concerned with risk of progression. And what we're trying to better understand are what progressive signatures are in fact present, but also not any two populations are exact. And what does that mean? Whether that's male, female, their gender discordance, also race, ethnicity, that hasn't really been critically investigated. And that's one of the specific areas that I have a invested interest, particularly considering the large data set that we have within the VA. But getting really to your question, are we at the stage now that we're applying targeted therapy and agents to knowing the particular genomic alterations that are in fact present? We are not. In fact, there are a number of clinical trials and investigations that are ongoing, but we're definitely not at the time where we're applying this in the clinical setting. I think it's a very exciting time. There's a number of very noteworthy investigators that are working collaboratively. I think the one thing that we're seeing beautifully illustrated in bladder cancer is the collaborations that are being established by a number of the top investigators in the country. And that's how we're really going to propel this field light years forward than to some other cancers that we're currently far behind in regards to better understanding. But if you think about even prostate cancer, the subtype classification and where we are with bladder cancer, I mean, it's almost, I don't want to say comparable because they're two different diseases and disease states. However, we've done a wonderful amount of work, and I think a large part of that is the collaborations and collaborative efforts. I think one of the things, as you all are aware, are the ongoing immune checkpoint inhibitors and applications, particularly with the Keynote studies. And I think we're going to be learning a lot more about this disease. The markers, whether their PD-L1 status, and how patients respond.
Right. So basically, that would be the future for us. That will open the gates for a personalized therapy for our patients. The next thing I'd like to take you to is because we mostly use the EAU or the AUA risk stratification for managing patients of non-muscle invasive bladder cancer. We divide these patients into 3 groups. Is there any other risk stratification model which is in practice in the USA? And do you use the EORTC or the Kyoto risk stratification models for prognostication?
Yeah, it's funny that you mentioned the EORTC because I have that calculator in my phone, for instance. And I did use that more so definitely prior to the risk stratification system. What's striking, and I think for a number of us, obviously, that are active in this field, is how so recent that, at least in the United States, the risk stratification has been implemented and also used and applied. And now, as we know, at least with publications and to compare as best we can, our data is to apply patients in these risk stratification categories. But an answer to your question is I use the current AUA, but also too, I really enjoy the EAU classification, and in so much also too the IBCG. They've also created some interesting, because it's the intermediate risk, right? That it's in the middle, right? And we're all concerned with those that may have those underlying mutations that we don't recognize at the present state that may carry a further increased risk of progression and don't want to undertreat those. Also, at the same time, we don't want to overtreat the low-grade tumors that just recurred less than 1 year, may not be the same size, but they're lumped into this intermediate risk category where you're on the fence whether or not to administer, particularly in a time of BCG shortages, BCG to those patients. So it's an interesting time. I'm hoping, and I think something that needs to be done, and we published just recently via the Society of Urologic Oncology, a survey assessment of particularly the low risk patients having a decreased adherence, to surveillance strategies. So, but I think we have to come, and I think we're doing a good job creating more of a homogeneous risk stratification system. But I think further work needs to be done so that we can better implement and then allocate appropriate treatments.
Williams, if I can jump in here, Tushar, I just wanted to discuss with you. You mentioned that about the BCG shortage that is being faced. What is have you made any changes to the maintenance schedule or the induction schedule of BCG, either in the dose or in the frequency or the duration of these maintenance schedules that you have because of the BCG shortage? And in your own experience, have you seen any difference in the outcomes or in the difference in are people recurring more or progressing more because we're not giving them enough BCG?
Yes, I think, excellent question, right? Because we're all facing this, which offers a tremendous amount of opportunity to collaborate and understand how we all are managing this disease, particularly in the time of BCG shortages or even in a pandemic. And I think the first part to your question is identifying the appropriate patients to receive. And we obviously at our institution, and I think worldwide would agree, is to allocate the BCG to those that are high risk, non-muscle invasive bladder cancer. And what we also tend to do is not alter necessarily the maintenance schedule, particularly for those we're aiming towards 3 years. But what we're doing is splitting one vial into 3. So reducing the BCG into 1/3 dose. Particularly when we keep a meticulous catalog of our BCG supplies. But another important fact too, aside from that, the 1/3 dose, is our active enrollment into the current SWOG 1602 trial, where we're investigating the Tokyo strain versus the traditional BCG. And that allows us a mechanism, if you will, to not necessarily suffer from the same shortages that are worldwide, as Merck will supply the BCG during these shortages. So that's another critical reason why I think centers should, aside from the fact of the shortage, enroll patients in that trial. But we really try to stick to the maintenance schedules as they're delineated, but alter the doses or split, if you will. And then you line patients up. I think another question, how do you do it? They're concerned, and Dr. Kamat just published, some data in regards for the duration that, once you split it, do you have to throw it away? We try to line patients up 3 in a day to where then you administer the 1/3 vial to each patient in that day, and you don't have to worry about the expiration or the vitality of the BCG itself.
And have you noticed any change in the recurrence patterns or the effectivity of the BCG by reducing the dose to 1/3?
I personally myself, and this is anecdotal, I have not. And I think, it goes back to the Odin's paper where they, critically evaluated the 1/3 dose as well as with the full dose. I do not see the increase recurrence or progression. But once again, I haven't evaluated this critically. This is a completely subjective, and objective data and quantification, I think, are needed to better understand this. But I think we are not seeing an increased, risk of recurrence or progression using the 1/3 or the split dose.
I just ask a short question.
Yeah, sure, sir.
In the intermediate risk, you included G2T1, the old style G2T1 or the low grade T1. Do you think that exists? Because it just feels like a misnomer. We are saying that it's a low grade and then we are saying there is a T1.
Yes. So I think and that's the problem, right? With intermediate risk. It's this heterogeneous group. Are we appropriately allocated? And also too, are we actually seeing those patients? I think we see definitely a lot more patients that may have the low grade TA that recur within 1 year. And then you would say, okay, they would be classified as an intermediate risk. And now is there a T1 low grade? Does that exist? It depends on each institution. They're pathologists. I could say at our institution, usually what we tend to see, and probably it'd be interesting to see, is T1 with high grade TA. So they'll say TA high grade and then invade the lamina propria. So
so in your institution, low grade T1 is not that often reported.
Correct.
Okay, because I always worry whenever anyone reports low grade T1, either they don't understand T1 or they don't understand the low grade. That's why I wanted a clarity on that. Thank you.
No, it's a great question, because T1, when I see T1, it's an ominous predictor. We know that. And you're absolutely right. I have a great relationship with our pathologist. Look at the slides, particularly he can find I came from MD Anderson, and his variant histology reporting is remarkable. But it goes back into the pathologist. He's expert trained. But I think it's critically important to also look at the slides yourselves when there's any question. But we have not identified T1 in particularly low grade. I can't remember a case when he's done that.
Thank you.
Thank you, Sanjay sir. Thank you, Dr. Stephen Williams, for that brilliant presentation and that discussion. We'll now move on to the next talk of the session. Our next speaker is from Singapore, Dr. Vineet Gohar. He is a principal resident physician, NTFGH, clinical lecturer, National University of Singapore, clinical faculty assistant, NUHS Singapore, and he'll be talking on innovations in transurethral dissection, how to make it better. We welcome you, Dr. Vineet Gohar, and you can share your slide, please.
Right, thank you so much, Tushar. Thank you to the program directors, Gagan and Dr. Raghavan, and to the whole team behind this wonderful webinar. I think it's really fantastic what Professor Stephen Lehman has just put across to us. And my topic here is to really address just the innovations in transurethral resection, how to make it better. But the key is that our problem is in bladder cancer is if you don't visualize it well, you don't resect it well, you don't get a good specimen, you're bound to have all these confusions that we were just addressing to Dr. Stephen Lehman. I mean, is it TA, is it T1, is it low grade, is it high grade? And I think the key to that is this layer of muscle, detrusor muscle, because we know that this cancer is notorious. Its recurrence rates, its progression rates, and no matter if it's a non-muscle invasive bladder cancer, you're not really very sure, because once the patient comes back to you for a surveillance cystoscope and you see some lesion over there, it brings you back to wonder, have I really missed the real line in this? So am I getting confused amongst the cats that which is the real line which I'm missing? And I think I allude back to this paper which was put up in 2010 by Dr. Param, that detrusor muscle is actually its first stop of determining how your bladder cancer is going to behave. And we know that in all the guidelines, everybody tells you, please make sure that your resection is good, because I think this is the watershed line and this is the Achilles heel of bladder cancer. So if you take that as your determinant, then everything has to be probably done revolving around it. What we really need is to see tumors better. We probably hope to be able to distinguish the benign one versus the malignant one just when we see them, and then the low grade versus high grade. And then, of course, we have to ensure that when we resect it, it's complete. What we have today are all these options, but what we are focused on are the first four. And I think enhanced cystoscopy, when we talk about it, blue light cystoscopy as its current flavor, the fluorescent cystoscopy, which is now even FDA approved and is done even as outpatient procedures, it's really good. It has a fantastic performance. We do know that it will give you a very good sensitivity, but the specificity is still a problem. And the problem is usually when you resect the tumor, you bring back the patient, and then you do a blue light cystoscopy. And sometimes you really don't know whether you're missing tumor or is that, especially in BCG treated patients or patients with inflammation. Again, we also have NBI, which is the most widely, I think, commonly used modality. If you use a SPY system, the stores, then it's probably equally good. I personally like the NBI. It's easier for me to see. And it's just a way of visualizing the tumor because it gives you a better contrast of the blood vessels. And this, I think, really helps you not only in diagnosing, but also in resection. Of course, there's this whole talk about fluorescent cystoscopy. And I think at this point of time, our focus is essentially, as was elicited in the AUA recently by this nicely presented topic, And it actually said that you can detect more Ta-T1 tumors. You are able to better resect them. It has definitely led to decreased progression, better satisfaction and confidence level with this. Clinically significant cancers, because that's the one we really want to pick up. We really want to pick up the lions amongst the pussycats. And then, of course, the false positive rates are also reduced. But if you look at PDD versus white light, I think there's just absolutely probably no comparison, but it's only one trial. So, Professor Stephen Lehman was saying, I think collaboration, and as we progress on, we will get all our information which we need, whether this is really going to be the one which picks up the lesions again. This is probably optical coherence tomography is great. Imagine if you can actually do a cystoscopy, put your optical probe, and actually try to distinguish those funny lesions, especially that are they the ones which are more malignant than the others. But its sensitivity and specificity is good, but it's really technically challenging. I mean, you are not able to really map the whole bladder with this probe. I've just had an experimental go at it, and it's not that easy at all. So I think at this point of time, if you look at PDD, NBI, SPIES, and probably PDD still wins, and it's probably a long-term follow-up which is going to be giving us the better answers. However, having said that, it does have a problem where sometimes the instillation gives you this bleaching effect. If you can have problems even when you instill the drug, you may not be able to see the lesions very clearly. So there are ways to circumvent that. It's all in the literature. But I think the more you use it, the better you get with it. The most important next step is resection techniques. Well, you can use white light, you can use NBI, you can use PDD. Whatever way you're resecting the bladder or whatever energy source, as we have so many today, it doesn't change the fact that you need to have a good resection. And techniques in resection have not something new. It's been there from 1993. If you look at this table over here, we've been having different ways people are trying to get samples in a better way. They've been using currents, or they've been using just simple things like this little paper here, which came up in 2017, which is talking about using snares. The whole point is you're trying to get a good specimen without any artifacts to the base, so that with a good muscle, of course, to try and get a better histology diagnosis of what you're presenting to the pathologist. So, with that, we know, when I always tell my residents, look, bladder tumor is dangerous. Bladder tumor needs you to remember all these M's for maximum success. And amongst the various M's of mapping the bladder, being methodical, do an NBI, etc., which we all follow, the most important is muscle is a must. And if it requires you to take a cold cut biopsy from the base, then so be it. And make sure that you re-inspect and make sure that you are definitely convinced that you've got enough specimen and the right specimen. Maintaining the margins also is equally important. So that begs the question that, we had TURBT from 1926. Is it still the gold standard? And I think we know that because of the recurrence and progression and the recurrence rate in 1 year or 5 years, with TURBT isn't the best, it's probably time to change. So we have to move from just getting fragments to getting the whole specimen. It's great when it's a small tumor. It's great when there is a single tumor. But what happens is when you have a bigger tumor, and we have a lovely debate which is coming up with the 3 centimeter tumor, because that kind of puts everything into perspective about, is this technique the way to go forward? But the potential benefits are that it prevents tumor fragmentation, and it probably gives you a complete resection in the smaller tumors. Even if there are multiple small tumors, you can get them wholly. This is information which I borrowed from my friend Tokus, and the whole point is you really want, when I do an en bloc resection, what do I want? I want everything to be perfect. I want this specimen to make sure that I don't have any recurrence. It helps me to bring down my need for second TURBTs. I've got good muscle in the base. But of course, while the principles are great, where you have a no-touch technique, you have a circular incision, but has it really allowed all these realities to manifest in the way that we want them to? But I think it is manifesting. It is, in something which is more and more people using day and day. We also have this wonderful consensus statement which has come out, which tells you, how do you do a TURBT? And how do you, en bloc resection, how do you do that? And how do you really get a good specimen to pass on to your pathologist? And then various consensus, about 99 statements. So if you get time, I think this is a good thing, which if people read, and it will make you more confident to do an en-bloc resection, because the number of papers and the number of studies which are coming out are quite phenomenal. And from 2014 to 2018, there's been a very steep increase in the number of studies which are coming out on en-bloc. And the thing with en-bloc is we are sure that in 2020 that it is better as a procedure when it comes to the patient outcomes. Much better in catheterization time, hospitalization time, complications, the dreaded obturator and reflex, perforations of the bladder, and of course the need for bladder irritation, which is because of dissection by using monopolar. Monopolar is of course outdated by bipolar current, but it hasn't really changed a big deal in terms of outcomes. I don't know whether this is something which prospectively is being evaluated, and we'll see whether there's a real problem with the way it's reported, the problem in the way which is interpreted, or is it just the disease, again, which is so heterogeneous in its presentation. But we do have all these energy sources. Amongst these energy sources, it's interesting to note that actually thulium is much better than holmium, which is much better than KTP, if you're using a laser. And if you look at the evidence, we had some literature which actually told us what kind of settings, but that was all in the early 2010s up till the 2015s. And though we had some understanding that, yes, 1.5 to 2 joules and maybe 40 to 50 hertz, and you can do a wonderful holmium resection. 2017, the number of studies which are really could give you some data out of them were hardly anything. And 2020, there's nothing. So what that makes you really wonder what's happened to holmium, what happened, because that's the commonest laser which is available for stones. And then it's probably best to use that for soft tissue as well. But I think the whole idea is that if it's lost into practice, there must be a reason. I'll come back to that a little later. But what we can see with thulium laser is that it really gives you a very good specimen. It has very minimal thermal damage, and it gives you very good sections of for your histopathologies to really look at and give you a better answer. But again, there's no difference in the 18 months recurrence rate if you compare a TRBT with a thulium lag ERBT. So that again, the thulium laser is not something which only every center will have, unless you're a dedicated center doing the really large volumes of bladder cancer. So the new kid on the block is the thulium fiber laser. Now we know what kind of laser this is. I've just put this little thing because I think everything to do with this laser is its bubble. The bubble formation and the dynamics and its absorption in water, which is twice that of thulium, versus the fact that the penetration of the tissue is half of that of holmium. It actually makes it probably a much better laser to use, because you may not be creating too many artifacts in your resection, and you may actually be having a better hemostatic result out of this. This is interestingly put forward by Scofone Cesare, who actually looked at both the lasers and said, if you take a holmium laser, and that's probably why I feel it's losing favor, is that it gives you too much of a depth of penetration, which we don't want in bladder cancer, because we want to go all the way down to that detrusor and get that sample to tell us whether there's tumor over there. And if you're going to char it over there, or if you're going to create this vacuolar or different coagulative necrosis down there, it may impede your pathologist from giving you a right result. But this wonderful thulium fiber laser, this is like a really good saber sword, because it's very precise. And like I said, for the same reasons what I alluded to, the depth of penetration and its ability to create an incision without causing too much artifacts makes it more efficient for cutting. So I think the winner right now is thulium fiber laser. And yes, there's some evidence which is coming out. The settings are better understood now. Russians were the first to get it, and I'm grateful to Professor Alexei for sharing this. So, they have very good results. They've been doing this comparatively with TRBTs as well. Small numbers, albeit, but I think there's a very, very effective role. There's a very potential role, because if you look at just this paper, you have 91% chance of getting your detrusor muscle intact for your histologist to really look at it and give you a better answer. Does that really mean whether we can pick up those pussycat and the real lines? I don't know, but it's something which is getting more and more commonly available, and I think we'll be seeing more of this. It's actually being implemented. This is a beautiful video which is put up in Video Urology. They did an interesting study where they used a thulium fiber laser with PDD with NBI, and I think they've shown that this really helps you to get you a better specimen. It's also useful using patients who are on antithrombotic agents, and you don't have to use muscle relaxant because you don't have to worry about obturator reflex and perforation. And this is one of the gentlemen, Chandramohan from Hyderabad, who shared his slide with me because he's been doing quite a few. And if you look at what's the problem with lasers is that there's a carbonization and there's coagulation, which is quite deep, and it goes down into the native tissue. So your pathologist has a problem, and that's to do with the specimen. But if you look at these two different specimens of bladder tumors, it's very well preserved. The coagulation zone is very less, and you're getting very good muscular layer. It tells you very clearly that this is not involved in the muscle. But there's something which I personally always note is that when you have a bigger specimen to send to your pathologist rather than fragments, and this is more pertinent when you have a less experienced person doing a TUR BT, for example, you may be missing the muscle in the area where the tumor has probably gone into. Whereas here, it's a nicer specimen. So you are less likely to miss the chance of those tumors going into the muscular layer. Again, can we better pick up? Is there a better diagnostic tool in imaging apart from cystoscopy? Yeah, we know VRADS is here. I think it's good, but it has to be studied. Even the EAU has still not yet certified this as a way to go forward. It has good specificity, sensitivity, but we are looking at those tumors which are non-muscle invasive, trying to prevent them from becoming dangerous cancers and to see how they will progress. I think that's where VRADS falls a bit short. But having said that, it doesn't mean that it's not in vogue yet. This was a small paper, a nice video again by my colleague and friend in Hong Kong. Colin Lowe has done BTESD, which is basically doing an endoscopic submucosal dissection along in patients who had an MRI, which shows you lesions. And they actually found that they have a very nicer, cleaner dissection, a better specimen. Of course, the blood loss is hardly anything and the operation time was minimal. But they could focus their attention based on VRADS onto those areas which they felt are the ones which are dangerous. And they did this in single lesions and multiple lesions as well. There's another friend in Japan who's doing this study. And Miyake is actually looking to see whether this PDD, which can be fused along with MRI, and that gives you a better chance of getting a more significant cancer, a better specimen, as well as a better resection. And again, we know innovations are happening. We have Zishan with us over here today, and it's very interesting because when he made this presentation, what he really pointed out was if you have a good anesthetist who's happy where there's no jerk, you have a scrub nurse who's just not too worried because you're not screaming, get me this biopsy forceps, and you're worried about the fact that you've not got good muscle. A pathologist who's very happy with the specimen because look at this clean specimen which you get using a cold en bloc excision. You get very nice staining of the muscle, you get very nice staining of the tissue, you have a good margin. So it's great when you have these smaller lesions because those are the ones who you can tell your patient more confidently, maybe surveillance cystoscopy, I don't think there's anything to worry about. So innovations are happening, innovations don't stop. I would like to thank Ashish and Mustafid for this slide. It's important to know that you can't always improve the operation, but you can improve yourself as a urologist. We've got to better train. We have to make sure that they follow checklists. There's a great checklist to follow in Anderson. The audits, if you're a specialized team, you're going to audit your own resections and the way your colleagues do them. Create the awareness that it's a lesion, it's a cancer which needs follow-up because quality of life is really something which the patient is going to be affected with. They need to be motivated to keep coming back. And I think all this is equally important apart from just doing the surgery. So I think in 2020, we've made very good progression. We have a lot more happening, but as far as my topic goes, I think the thulium fiber and the lasers are here to give you better specimens. With that, I'd like to say thank you so much for the opportunity.
Thank you very much, Dr. Vineet Gohar, for that colorful presentation. You had some beautiful pictures of bladder tumors in your slides. You've been a pioneer in this field, and we would love to hear your practice about a section of these tumors. My first question to you would be, Before TURBT, while doing a cystoscopy, do you make it a point to always use narrowband imaging and PDT for cystoscopy before TURBT?
Yeah,
or you go ahead with white light? Sorry, yeah.
Well, in the outpatient setting, yes, there's NBI and there's white light. We compare them. The mapping of the bladder is done always using that. When we take the patient up for surgery, in 2009, I was working in NUH with the Professor Kesavan, who was doing a lot of work on PDD then. And initially, we know the problems which are associated with PDD is the staining, the ability to read whether this is a correct specimen. And I think those things have been highlighted now to be better. So we are right now trying to keep those for that subgroup of patients who probably the pathologist tells you that, there's no muscle over here, that we missed that muscle, or we look at those patients who've come back with recurrence very early to do a more complete resection. Otherwise, PDD, I must say, in my practice, I don't really use it too much. My colleagues who do a lot more, they haven't really been emphasizing on this yet. But I think it's the expense and the cost, which is probably a little bit of the reason. But we do have great system from SPICE and NBI, and that's actually pretty good for non-muscle invasive bladder cancer as well.
Right. Thank you very much. So moving ahead, do you generally use electrocautery or you prefer the laser in your practice for resections?
So the presentation says so many sources of energy. I would say I use bipolar current as well. My bipolar resections, I generally bring down the settings to really low. It's for those innocent tumors, which I know it's very easy and I'm not going to be worried about getting any problems. Then I just use a bipolar loop. I did use the holmium laser. I have stopped because my pathologist was a bit upset with me because they did find too much of tissue charring. Though I found that I get a better resection margin. I have used the thulium fiber laser in India with some colleagues. We did some essential work there. I think it's beautiful. I have no experience with the thulium YAG laser yet. But...
So you would prefer the bipolar over the monopolar for resections?
Oh, yes, of course. No doubt about that.
Perfect. One more. Sorry. Yeah. So one more question for you. Considering a 7 or 8 centimeter tumor, which is frankly muscle invasive on imaging, what is your the patient has come to you for the first resection. What is your practice generally? Do you go in for a complete resection, even if it needs a staged procedure, or would you take just a biopsy, ensuring the deep muscle is in, and you come out?
It depends on a lot of other parameters, like what patient has presented with, to be honest, and the age of the patient and his comorbidities. So if I can, I would always aim for a complete resection the first time, ensuring that I get my muscle for sure. But if I find that it's preluding me from doing a complete resection for other reasons apart from the fact that the tumor is not resectable, then I would probably stage it and come back for patient safety. But I would come back early then. I wouldn't wait too long there.
Right. Continuing from there, if it's a 3 or 4 centimeter tumor and you're sure that you've taken the muscle with the biopsy specimen, the biopsy reads it as T1 high grade muscle included in the specimen. Would you go ahead with a restage, or you would go ahead with a management of a T1 high grade tumor?
Well, if I've had a complete resection,
right,
and I'm sure that there's nothing inside, then I would just go ahead with the management.
So you might omit the restaging procedure for this patient?
If I'm really, really confident, even if it's 3 centimeters, I think the size is, it's important, the size, but the worry is when you have a 3 centimeter lesion with funny looking arterial architecture in and around, where you're worried about CIS. Right. So I do tend to take biopsies too. And EAU also tells you, so I do tend to take that. I'm very, very, if I use the word, I'm very, very, in Singapore, when they say kiasu, you're always worried about the urethral involvement into the prosthetic urethra. So I'm keen to do that when I see these bigger tumors or multiple tumors for sure.
Right. So you take a biopsy from the prosthetic urethra too. Right.
Dr. Vineet, if I can jump in, just, fantastic talk as usual. Heard you many times now. So I wanted to ask you, do you have a certain cutoff for the on-block resection? Would you say that, okay, above this, I'm not going to try it, or below this, it's definitely going to be on-block?
Yeah. So that's a great question, because when my friend Jeremy Teo in Hong Kong, when he brought this up in Singapore in 2016-17 at the first presentation in the Eurofair, I was excited and I started doing them for all the 1 centimeter, the smaller ones. I was doing bipolar. With the holmium, I got pretty creative, and I would go right up to the 3 centimeters, even the carpet-like lesions, because the patients didn't have so much of irritation. They were not complaining too much. But I realized that I think the cautery effects that because of the holmium laser, they are not that good. And I wasn't really having a very effective resection in a bigger tumors. So right now, even if they are multiple, it doesn't matter. The location, again, doesn't matter. But I try not to go more than 2 centimeters, maximum 3 if it's got a nice top.
Right. And any tips or tricks in terms of how to get that kind of bunch of tumor out through the resectoscope? Yeah. Any problems faced with that and how to do that?
Yeah, that would be another important question. But yeah, so I think when you realize it's this big specimen that you're going to come out, take the base of the tumor, get the whole specimen out. Sometimes what I've done is I just kind of halve the specimen and pull it out. It's much easier. There has been a time where I've actually put in a bigger size nephroscope and taken it out. It's much easier to take it out with that as well. But I think we don't have those bags to catch the tumors and take them out, those bigger ones. But most of them are soft and collapsible, so it's okay.
Dr. Kulkarni wanted to say something, sir, please.
Well, suppose if the tumor is involving the ureteric orifice, what is your plan?
Yeah, good question again. So I think there's no question about it that oncology takes precedence. They absolutely fine. Sacrifice the tumor, the orifice. You can go well into. So we've gone into the orifice. We've resected the orifice. We've actually gone into the proximal ureter. Into the distal ureter. I've left you don't put a stent inside. It goes back to the same principles that we know, Professor Kulkarni, that you don't diatomize to cause stricturing of the ureter. You just leave the opening alone. These are the tumors where we use gemcitabine. I actually make sure that I do use gemcitabine for them.
Can I just ask one question?
Right,
so thanks for covering those specific aspects of it. But let's say if I was planning to use thulium fiber laser, what is the main advantage other than the rare situations wherein the patient is on anticoagulation? What more am I getting by using a thulium fiber compared to, let's say, bipolar TURBT?
Yeah. So I think if there has to be one single line answer to that, you will 100% get a better specimen to your pathologist, because you can really go wide in your margins and resect out the tumor, which is not fragmented by a TURBT. And if you do that, you'll realize it's very, very hemostatic. And the resection times, even the bigger ones, the more difficult tumors, are less than 20 minutes. And I think you'll be happy with that.
Thank you.
Thank you very much, Dr. Vineet Gohar, for the beautiful talk and the discussion. We'll move on to the second session. Our first speaker in the second session is Dr. Jinil Kumar. He is a professor in Department of Urology and Chief, Division of Uro-Oncology at Amrita Institute of Medical Sciences, Kochi. And he'll be talking on insights on BCG. Where do we stand? Dr. Jinil, you can proceed with the talk.
It's a great privilege to be in this podium. Actually, the introduction was already given by Stephen about the BCG. Given the task of compiling everything about BCG in 10 minutes, which is a very difficult task, which Gagan has given me. So, the story of BCG starts almost 100 years back from Pasteur Institute, where this bacteria was isolated from a cow's jaw, which was infected by tuberculous mastitis. And we have to thank Calmette and Gowring for it. And different strains of BCG is spread across the world now, which was originated from the Pasteur Institute. And every country has their own strain strain, which is a mark of that area. Like BCG Danish is in our country, then BCG Thais is in US. Like that, different countries use different BCG strains. This BCG is there for the last 40 years, thanks to Morales for his great invention, one of the most important inventions in the field, not only of bladder cancer, but the entire oncology. how to use immunotherapy to tackle tumor. And how he started, he had 7 vials of BCG in a pack, and he used it as 6 vials of BCG and used as 6 doses. That is how the dosage started initially. And even now, after 40 years, the same dosage schedule stands. After 40 years, when we check the NCCN guideline, we see that it is the standard of care in high-grade tumor and T1 tumor, and an option in low-grade tumors also. The mechanism of action is still unknown because it's very complex. It involves a lot of cytokines, a lot of inflammatory molecules, and it's thought that BCG attaches to the urothelium with a fibronectin molecule and stimulate the cascade of reaction, which finally ends up in the death of the tumor cells. What is the optimal dosage? A lot of things about BCG we don't know. We don't know the optimal dosage also. Different strains has got different dose, different schedule as given with different dose, and most often used or most evidence is for SOGO protocol dosage, which includes 6 weekly initial dosage followed by a maintenance of 3 weeks, then followed by 3 weeks at 3 months, followed by 3 weeks at 6 months, every 6 months, 3 week dosage for up to 3 years. So induction plus maintenance, that is the usual course of BCG scheduling. But whether this is the best protocol from India itself, actually, Dr. From PGI Calcutta, they had a paper telling that this SOGO protocol is equal to monthly protocol. So everything is challenged in BCG. Are different BCG strains different or equal? A lot of papers telling that they are similar. But there are some papers to say that there are some difference, like in one of the paper, they say that Tokyo strain is better. Then another paper from England says that Connaught is better for induction, but if you are giving maintenance, BCG titers scores over BCG Connaught. Different communities, should we have the same maintenance protocol? Still, we don't know. We had a study of our patients and found that in patients who was given less than 1 year and more than 1 year, there was no difference in the total outcome. So in the patients who are exposed to tuberculosis and where the vaccination is there, BCG vaccination is there, should we give the entire maintenance? That also we don't know. Can we manage with the smaller doses? Gagan was asking Dr. Stephen. Yes, there are 2 major trials on this. Kyoto study showed that 1/3 dosage is comparable to MMC, and 1/6 dosage is suboptimal. But URTC found out other way around. If you are giving 1/3 dose for 1 year, it is suboptimal compared to one full dose 3 years. So there is a difference. And in high-risk patients, according to URTC study, they recommend full dose for 3 years. But we know that up to 1 year is the minimum duration we have to give. After that, it improves the recurrence rather than progression. So at least 1 year we have to give, and preferable to have 3 years full dose for high grade. Regarding between mitomycin C and BCG, if you are giving maintenance, BCG scores over mitomycin C, either mitomycin C given as an induction or as a maintenance. But if you are not giving a maintenance with BCG induction alone, it is inferior to mitomycin C. How effective is BCG compared to other intravesical chemo? There is no good data against mitomycin, but thing is, if you are compiling all the intravesical chemo, we will say that there is around 27% reduction of, there is no much data to prove difference between mitomycin, but if you are comparing with intravesical chemotherapy, there is around 27% reduction in the chance of progression. and is there across papillary tumors and carcinoma in situ. But this is seen only if you are giving the maintenance. But curious thing is there is no benefit on the overall survival or in the cancer-specific survival by BCG in any of these studies. In progression, still, yes, again, there is difference with mitomycin C only if you are giving maintenance dosage. If you are giving induction alone, there is no difference in the progression comparing with mitomycin C. We have a Cochrane review this year, which tells that compared to mitomycin C, there is no time to death for any causes. There is slight difference in the recurrence. That is, HR is 0.88, and there is not much difference about progression. So what we have to believe about the action compared to mitomycin, still, even after so many meta-analyses, we don't know that is a fact. So gemcitabine is the in thing now because of the COVID and a lot of factors. Gemcitabine is replacing BCG in a lot of countries. So we have got evidence to say that, at least there is a meta-analysis to say that there is, regarding recurrence and progression, it is almost equal. But regarding side effects, gemcitabine is better. But more studies and more analysis required about this data. If you are sequentially giving BCG along with mitomycin, what will happen? There is no difference in the large volume study of URPC. If you're combining with interferon alpha, what will happen? There's a Cochrane review. So there's a difference in the chance of recurrence, but regarding progression, there was no difference. And curiously, about the side effects, adverse events, also there was no difference if you are giving BCG alone or interferon alone. So now we'll move on to the cause of failures in BCG. Most important neglected thing in BCG failure is the surgeon itself. If you are understaging the tumor, second, if you are doing incomplete resection, or if you are giving a BCG that's not properly stored, or if you are giving inadequate doses, these are the main things we have to be careful about. There are a lot of patient factors which are important. One is actually the BCG has to get adherent to the urothelial cell with fibronectin. This can be a factor. Sometimes the tumor, the T1 helper response may not be adequate, like in old age or immunosuppressed may not be adequate. That can be a factor. The genetic instability of the tumor is another factor. Now, most important debated one is the PD1 and L1 because this is very important in the BCG failure treatment. BCG failure I am not going to, but the most important thing what I want to highlight is now there is a definition, it is properly defined so that we can have studies on BCG failure because that is streamlined. The definitions are streamlined now. Regarding the markers of response of BCG, most important thing are the patient factors or disease factors. And there are some markers, these are prognostic, predictive markers, but thing is there are investigation markers which are important that will come across. So there are two risk tables which are important to predict the failure, BCG failure, but this coincides with the disease factors itself, which are prognostically important. So stage grade carcinoma in situ are most important factors. If there is a carcinoma in situ along with the primary tumor, it can, or in the prostatic tumor, if there is a carcinoma in situ, that is a predictive factor. Age above 70 and females has got increased recurrence after BCG according to Kyoto study. And predictors of recurrence are just like other, like in the bladder calculators scale. Most important immune response, I will say, is the stimulation of T helper cells 1, because Th1 helps in the potentiate the action of BCG, but Th2 actually the recurrence chance is higher if Th2 level is higher. What are the markers? There are 3 markers which are clinically useful but not used because of a lot of factors, like it is not generally available in the community level. One is FISH, second is Cyprit nomogram. Both these are actually first order was Ashish Kamath. And Cyprit is one thing that is validated recently and may be useful because it accurately predicts up to 85.5% in BCG response. Separate is actually a compilation of lot of cytokines and is evaluated. Another thing is the genetic alteration that can happen. There was a large study that also actually, along with the clinical pathological risk score, it improved the assessment by almost from 0.68, it has increased to 0.8 to area under the ROC curve. So this is also useful. Molecular markers, different molecular markers are studied, but none found to be useful in the clinical scenario, including FGFR3. Most important thing that is coming up is the PD-L1 inhibitor status, because this is an independent predictor of failure. And we know that pembrolizumab is recently approved for BCG failure. So this is going to stand. Can medication alter BCG response? There are a lot of studies. Statins, in one study, there was a reduction in BCG effect, but another study, it was almost confusing. Anticoagulation increased the chance of recurrence. Aspirin reduced the chance of recurrence. Isoniazid and antibiotic sometimes we'll be giving to reduce the BCG reaction. In last studies, they found that there is not much effect on the recurrence really if you are combining isoniazid or Now, finally, on the COVID, how to change the strategy. In induction, if there is a COVID positive patient is coming, we can postpone the BCG for 3 weeks. And if the patient is negative for COVID, we can start with the instillation. In the maintenance, if he has already covered 1 year, there is no benefit by proceeding further in this COVID season. But if it is less than 1 year, if you want, you can skip 1 dose, because there is no much data to say that this 3 dose itself is required. We can compromise with 1 dose. That is one study that has come in European urology. Thank you very much.
Thank you very much, Dr. Jamil, for that exhaustive talk on BCG. As you mentioned, everything has been challenged in BCG in bladder cancer. I cannot agree with you more on this, except for the fact that the initial induction dose of 6 cycles still remains as was introduced by Morales. It was by serendipity that he used the 6 weekly doses because it came in 6 vials and it has continued forever. I have some very quick questions for you because everything in BCG has been challenged, as you said. Between the SWOG or the EORTC, which has a 3-monthly maintenance protocol versus a very rampant 1-monthly maintenance protocol in our country, which do you prefer and follow?
Actually, in our department, one unit uses the 1-monthly protocol and my unit uses the SOG protocol. So right. We studied the thing. We are just trying for this publication. We studied and there was not much difference. And curiously, in our study, we just assessed the patient who had less than just a maintenance and skipped out, and who had more than 1 year of BCG, and found that there was no recurrence or progression rate difference at 2 years. So we don't know exactly whether in our country this maintenance is. We have to have more studies, then only we can say that it's. But from the West, we know that maintenance has got a role. But in our country, where tuberculosis is prevalent and where all the patient has got already taken BCG immunization, whether this maintenance scores, we don't know exactly. That is my answer.
Right. As far as the efficacy is concerned, you feel both are equally efficacious, the SWOG and the 1-monthly, right? Okay. Then my next question would be to you is, what is the lowest minimal dosage of BCG acceptable for an efficacious response so that the efficacy doesn't go down? Because we know with high doses, there are a lot of side effects, and so we tend to decrease the dose.
So, according to Kyoto study, it is 1/3 of the dose. When they reduced 1/6 had suboptimal effect. But that should be what I will say is that should be according to the grade of the tumor. If you're having a high-grade tumor, don't compromise, give the maximum full dose. And this full dose also, we should not get carried away with the dosage in the West, because different countries has got different milligram dosage according to the strain. So ours is 120 milligram, half doesn't equal to 27.5 milligram used in Kyoto study. So we should be careful about that. That is the most important thing. But we have to just calculate half the dose or 1/3 of the dose. And in high-grade, high-risk patients, you have to give a maximum dose. I feel that is better not to go. But in our country, as I told, whether we have got excess immune response compared to the Western population, we are not sure. That is a point we have to analyze and find out.
what do you think is the tolerability profile of our patients as compared to the US? Do we fare better than the Western population as regards the tolerability of?
In our study, we had around 60% of individuals having side effects because of BCG, and it must be almost comparable with the West.
Okay, right.
Or in some of the areas, they say that it is increased in Indian population because of the exposure to BCG in the past, but also it's comparable.
Right. Dr. Stephen Williams has a question. Yes, Dr. Stephen.
Dr. Puluri, thank you so much for that wonderful presentation. I had a question that was very interesting in regards for post-operative administration of chemotherapy, at least by and large, at least in the Western countries, is administration in those low-risk patients, restricting the intravesical chemotherapy. How is it over, in the UK or particularly in India? Are you restricting the use? And it seems like we all have shifted from utilization of mitomycin to gemcitabine. Something that I found also equally as provocative, although we use it for the BCG unresponsive patients, is the administration of gemcitabine. And I think compare that would be interesting.
So main factor I feel is the cost in USA. I think mitomycin availability is very less now, and cost is escalated. There is one factor because of it, gemcitabine shifted out. But in India, gemcitabine is very costly and mitomycin is available. So we still, even now, we continue with the mitomycin installation on the first day.
Right. Thank you. Thank you, Dr. Stephen. Thank you, Dr. One last question for you. For all high-risk patients of the high-risk category, do you go on for 3 years or you stop after 1 year?
I attempt to go for 3 years, but majority stops at 1 year.
Right. Thank you very much, Dr. Janul, for that beautiful presentation. We move on to the next talk. The next talk is by Dr. Roger Lee. He is a genitourinary oncologist, consultant urology from the Moffitt Cancer Center, Tampa, Florida, USA. He'll be talking on Beyond BCG, how to treat BCG unresponsive disease. We welcome you, Dr. Roger Lee, and you can go ahead with your talk.
Thank you so much, Dr. Narain, for the invitation for me to speak here on this platform. And thank you to all my friends in India, including Dr. Rawal and Dr. Gautam for this invitation. And in particular, special thank you to Dr. Ashish Kamat, who's been my mentor, who taught a lot of things that I know about BCG and also how to treat BCG unresponsive disease when BCG does not work. So I'm excited to talk to you a little bit about the BCG unresponsive definition and also several of the emerging treatment modalities that are in this field today. So just a slide on my disclosures. And I'd like to start off by illustrating a case. And so this is a patient that we typically will see oftentimes in our clinic, a 72-year-old gentleman with gross hematuria with some medical comorbidities. You diagnose him with T1 high-grade bladder tumor. And on re-TUR, he was found to have no residual disease. He then starts BCG induction, followed by 3-month surveillance cystoscopy, at which time he was found to be tumor-free. And so he undergoes an additional 3 weekly maintenance dose. And finally, at 6 months, he was found to have recurrence, unfortunately. And the biopsy shows that he has T1 high-grade disease. So this is a particularly challenging clinical scenario where there are several different options. We could either repeat the BCG induction for this patient. We can take the patient for an early radical cystectomy, or are there other intravesical agents that are at our disposal to treat this particular type of disease? And so in considering whether more BCG is going to work, there are several different factors, given the convoluted course and of induction and maintenance that Dr. Kumar had just alluded to. So some of the things that we might want to consider are the timing of the recurrence after BCG was initiated. How many courses of BCG does it take for us to know that there is adequate BCG administered such that additional BCG installations is not going to be efficacious anymore? Does the grade of the recurrence matter in terms of its prognosis or recurrence-free survival? And finally, are BCG refractory disease and BCG relapsing disease one and the same? So as we all know, in 2016, Dr. Kamat and the rest of the IBCG had came up with the definition, the endpoints, and also some recommendations for clinical trial design in this space for non-muscle invasive bladder cancer that are resistant to BCG. And in this paper, they actually combined two different clinical entities, that of the refractory disease or persistent high-grade disease at the 6-month mark after adequate BCG, and also the relapsing disease or high-grade disease that recurs after the patient is found to be disease-free at the 6-month mark. And in this paper also, they defined what exactly constituted adequate BCG as at least having received 5 of 6 induction installations, and also at least 1 maintenance or a reinduction that constituted 2 of 3 or 2 of 6 installations in a 6-month period. And since the publication of this paper, this definition by and large have been adopted by the US FDA in terms of enrolling patients for BCG unresponsive disease. So with that in mind, I just wanted to take a little deeper dive into the data that's behind why these definitions were put in place. So first of all, regarding the timing of recurrence, this is a paper that came out of University of Iowa, where a group of investigators led by Michael Donnell et al. Looked at, in 2006, they looked at the efficacy of combination BCG interferon in treating those patients who have high-grade recurrence disease after BCG. Although that trial did not pan out, they actually re-examined the results, specifically looking at the timing of recurrence from the previous BCG dose in predicting whether a patient is going to respond to additional BCG plus interferon combination therapy. And what they found interestingly is that the timing is different for CIS versus papillary disease, in that if you have recurrent CIS after BCG treatment, that failure within the first 12 months actually predicted a failure rate to additional BCG plus interferon combination therapy, whereas for recurrent papillary disease patients, the critical timing is actually within the first 6 months. And again, this 12-month of failure after BCG has again been adopted by the US FDA in coining the BCG unresponsive definition. What about how many courses constitutes adequate BCG? So in that same paper out of the University of Iowa, they also found that for those patients who failed more than 2 previous induction courses of BCG had worse outcome, 2 additional BCG plus interferon therapy. And we also looked at this in the MD Anderson cohort, where we compare the patients with high-grade recurrences after induction alone versus the patients with high-grade recurrences after induction plus at least additional course of BCG, i.e. adequate BCG. And what we found by comparing those two, as you can see on these KM survival curves, is that the recurrence-free survival, the progression-free survival, as well as the cystectomy-free survivals were all markedly more poor in those patients who had high-grade recurrence after adequate BCG in comparison to those patients who have high-grade disease after induction alone. And then what about the grading on the recurrent tumors? So not surprisingly, we found that, again, from the MD Anderson studies, that the high-grade tumor recurrences constituted a worse recurrence-free survival, progression-free survival, and cystectomy-free survival. However, if you look carefully at the progression-free survival curves of the patients with low-grade recurrent disease, you notice that at 5 years out from the time of initiation of BCG treatment, that there is about a 15% progression rate in these patients. So not an insignificant amount of patients with low-grade recurrences after BCG initiation will actually progress to muscle invasive or distant metastasis. So again, stressing the importance of continued surveillance in these patients. And finally, the concepts of BCG refractory and relapsing disease have not really been examined in detail in the literature. Besides one small paper from the MSK group, which looked at the two different groups of patients after BCG failure who then went on to mCNA, or the Mycobacterium flea cell wall and nucleotide extract as a salvage agent. And what they found was that the refractory patients actually did much worse on the salvage treatment in comparison to the relapsing groups, both in terms of recurrence-free survival as well as progression-free survival. So we actually extended this study to the MD Anderson cohort again, and limited by the number of patients that we had of BCG unresponsive disease, we didn't really see any difference. But then again, if you really look at the curves, there really isn't a lot of difference there. And hence, this supports the IBCG definition and grouping the BCG refractory and the BCG relapsing groups as one and the same in terms of enrolling for additional BCG unresponsive trials. So that's all fine and dandy about the data behind the definition. Well, does the definition of BCG unresponsive disease actually matter? So with that question in mind, we actually looked at the mCNA trial, and we picked out those patients who strictly fell under the BCG unresponsive umbrella and compared it with those that did not. And we actually did see there was a small but statistically significant difference between the two groups, such that BCG unresponsive definition is an important clinical entity that we have to tease out in order to enroll patients in these BCG unresponsive salvage agent trials going forward. And so what about the treatment of BCG unresponsive disease? As we all know, and I'm not going to steal the thunder of the next speaker, Dr. Monaharan, on the use of early radical cystectomy and BPL&D as the gold standard for BCG unresponsive disease. However, as we all know, even in the Western world, as well as in India and the UK, morbidity remains high. Still in this modern era with robotic surgery as well as ERAS protocols. And many of our patients who were unresponsive to BCG will not tolerate radical cystectomy because of their multiple comorbidities. And in this setting, of course, conservative treatment strategies are much needed. So in talking about the efficacy of salvage treatments, we really have to set some guidelines and benchmarks. And a certain set of benchmarks were set by Dr. Kamat et al. From that 2016 paper, where they deemed a 50% CR rate after recurrent CIS at 6 months to be a clinically significant CR rate, whereas for 12 and 18 months, the recurrence-free survival for both CIS and papillary disease decreased to about 30 to 25%. At the time, it was really thought that these benchmarks were attainable, but given some of the results that I will be going into a little bit later on, these targets actually are very, very high targets for us to hit. So compared to some of the trials that have been done in the past, including valrubicin that has been approved for use in the US for BCG unresponsive CIS, you could see that the 6 month and the 12 months disease-free survivals fall way short of those benchmarks that were set by Dr. Kamat et al. There are some small trials, including the one using Abraxane that did meet those, but again, we know that the efficacy marks oftentimes will fall off when you move from a phase 1 to 2 to 3 clinical trial setting. So with all of that in mind, we also looked at using a systematic review of all of the different bladder preserving trials that have been done in the past, encompassing 42 studies of over 2,000 patients who were subjected to intravesical treatment or systemic treatment who did not undergo radical cystectomy. And what we found was that the the efficacy of bladder sparing therapy was drastically different for those patients with CIS containing tumors versus those with papillary only disease. And that with CIS containing tumors, you can see the 6-month and the 12-month CR rates were at 26 and 17% respectively. Whereas for those with papillary only disease, we're looking at 67 and 44%. So very high compared to the CIS containing tumors. And again, echoing back to the difficulty of us containing this CIS containing tumor. The silver lining for this study was that in terms of progression-free rate, whether the patient had CIS recurrent tumor or papillary recurrent tumor, that the progression-free rate for both of those disease entities were fairly high when using bladder salvage therapy. So in conclusion, we thought that there was only modest efficacy up to date for all of the bladder sparing therapies that have been done in the past. And we look forward, obviously, to the different trials that are coming online in the future, in the near future. So what are some of those therapies? There was a study that was published again out of University of Iowa looking at sequential gemcitabine and docetaxel, and I think Dr. Williams had touched on this earlier in his talk, where it was shown that 1 year and 2 year recurrence-free survival after instituting gemcitabine and docetaxel were found to be excellent at 65% and 52%. Even in the CIS containing BCG unresponsive cohorts, they found that the 2-year recurrence-free survival were better than 50%. And that's much higher than any of the different clinical trials we have to date. These investigators also found that there was a very low progression rate to muscle invasive disease after using this intravesical therapy regimen. And of course, we know that this is a retrospective study and it's limited by those inherent limitations. And so again, prospective randomized controlled trials need to be done in this setting to evaluate the efficacy of this combination. Intravesical rad interferon with SYN3 is another agent. This agent used to be called Instilodrin. Now it's advertised by Fairgene as Adstiladrin. Essentially what it is an adenoviral vector that's been used to instill within the bladder, and that the adenoviral vector actually transduces interferon into the urothelial cells, whether it be a cancer cell or a normal urothelial cell, such that the urothelial cell will then turn into an interferon factory such that it will produce interferon long term. The advantage of this drug is that it's only instilled one time every 3 months, and patients find that to be much more convenient than BCG. And it's also found to be very efficacious. In a phase 2 trial enrolling only BCG unresponsive disease patients, it was found that the CR rate at 6 months was 44%, and 12 months recurrence-free survival was at 35%, again, meeting those benchmarks that were set by the IBCG and Dr. Kamat. So with the enthusiasm that was generated from that phase 2 trial, a phase 3 trial has been recently completed, a multi-institutional trial that was done through the SUL CTC, and the preliminary results were presented by Dr. Denny et al. At the SUL last year in a cohort of 107 patients with CIS plus or minus papillary TA or T1 disease. And you can see that this was a very heavily pretreated group with over 50% of the patients having had more than 3 courses of previous BCG treatment. And in this cohort, you can see that above 50% of the patients were found to be disease-free at the 3-month mark. And out of those, 76% were found to have durable response at 6 months, and 45.5% were found to have durable response at 12 months. And so 25 out of 107, you're calculating about 20 to 25%. Still not a great number of patients who were found completely to be disease-free, but that's a significant number of patients who are disease-free at 1 year out from BCG unresponsive disease. Another key study that's in this field was the Keynote 057 study using pembrolizumab IV in these patients with BCG unresponsive disease, in which about 100 patients with CIS containing BCG unresponsive disease were studied, 41% of whom remained with a complete response at 3 months out from the time of treatment, with overall about 20% patients remaining continuing to have a CR at least 1 year out from treatment. And we know that the median duration of response was 16 months. Even though these were modest in comparison to those benchmarks that were set by Dr. Kamat, as well as our comprehensive review and meta-analysis, the FDA still approved Pembro for this treatment of BCG unresponsive patients because few of these patients were found to progress to muscle invasive disease. None of the patients were found to have metastasis. And really, alternative to this treatment is bladder removal, which we know comes with the morbidity and the mortality that the procedure entails. And finally, the patients with CR can delay cystectomy by about 5 months. Some of the newer agents that are coming online, one of which that I'm particularly interested about is oncolytic virus. And so the oncolytic virus actually attacks the cancer cells through a two-pronged attack. Number one, it directly lyses the cancer cells through mechanisms that are genetically engineered. And number two, through the attack of the cancer cells and the lysing of the cancer cells, it actually releases tumor antigens that then elicits an anti-tumor immune response that then eliminate the rest of the residual tumor cells. So one of these agents is called CG0070. It's an adenoviral vector using the E2F promoter to target only those cancer cells with an RB defective gene, and also along with it, a GM-CSF gene that's knocked into the viral backbone in order to recruit additional immune cells to the microenvironment. And in a couple of the presentations that were made in the AUA and the SUO, you can see that the 12-month CR rate using these drugs in the CIs containing cohort was 27%, overall was 30%, even at 18 months, close to 20% in the CIs containing cohort. And in comparison to enstiladrin, valrubicin, and also vincinium, which is another exploratory agent in this space, you can see that the 12-month efficacy rate is quite comparable to enstiladrin and much better than that of valrubicin or vincinium. So bolstered by those data, we're actually poised to open a clinical trial in the BCG unresponsive setting using a combination of this oncolytic virus, taking advantage of the fact that it elicits the immune system, and then combining that with a PD-1 inhibitor in pembrolizumab to treat these patients with BCG unresponsive disease. We're very excited about this trial. It is enrolling through the SUO CTC as well, and we look forward very much to the results. So with that, I'd like to thank all of my friends for your close attention and be happy to answer any questions anybody may have.
Thank you very much, Dr. Rajali, for that exhaustive presentation. You've covered everything about this, one of the most difficult topics in non-muscle invasive bladder cancer. I had a lot of questions for you, but your slides have answered almost every question. It's really heartening to see the immense research that is going on, especially about the viruses being used for treatment of NMIBC. I have a very, quickly I'll ask you a few questions that I have for you. BCG refractory and BCG relapsing tumors, do you think there are different biological variants and they need to be assessed differently on the genetic basis so that we can offer different treatment for them, or all of them are same and we should go ahead with a radical cystectomy in all of them?
Yeah, and that's an excellent question, Dr. Narain. And I think a lot of the speakers have touched on this subject before, but I think a key factor in determining refractory disease in particular is the expertise of the surgeon in resecting the disease completely on the first try, and instituting adequate BCG. So with that being said, I do think that there may be some differences biologically between the two. in that the BCG relapsing disease may be initially responding to BCG and then recurring, which means that, inherently it may be a biologically, more aggressive type of disease because it's already undergone the clonal selection that BCG with its ensuing immune response actually has eliminated all of the, the cells that are not very viable to treatment, and then selected for those tumor cells that are then resistant. But, again, from our study at MD Anderson, even limited by the small numbers, we didn't really see any difference in terms of recurrence-free survival, progression-free survival. And I think that's a very key question going forward. Here at Moffitt, we're also looking for collaborators throughout the world. So, being that BCG is in use in so many of your centers, more than happy to discuss offline regarding collaborations in that regard.
Right. Thank you very much.
Sure, I have a question.
I think you'll have to wait for a few years for that to come. One last question for you. Patient with a BCG refractory tumor, he has refused radical cystectomy, although he's fit for surgery. What is your take for this patient? Would you offer him a second course of BCG? Would you offer him systemic pembrolizumab, gemcitabine, or gemcitabine docetaxel combination? What is your practice?
Yeah, so again, a very excellent question, and a clinical scenario that we unfortunately face in our clinical practices very frequently. I think in this patient population, if they were to refuse radical cystectomy, bladder sparing therapy obviously would be the next best choice. And it's really in our, we have to kind of know the data behind the various intravesical salvage agents to know which one to pick. My main knock against a systemic pembrolizumab is its toxicity. Even though it hasn't really been reported out, but as we all know, PD-1 inhibitors sometimes will elicit the immune system too much, that it induces autoimmune disease in terms of colitis and pneumonitis, all of which are very serious ICU requiring treatment modalities needs to be instituted. Even though it wasn't reported in the Keynote 57 trial, there was one patient who wasn't in the CIS cohort that actually ended up dying from that trial. So, I think the toxicity of systemic pembro is, is to be considered. But then again, you also have to kind of compare that with the efficacy.
Right.
And that's why we're using it in combination with this inciting agent in the oncolytic virus, hoping that with the combination of the two, you're going to get not only an additive, but also a synergistic effect between the two. So with that being said, right now, I think Gem-Doce, based on that multi-institutional study, looks very promising, although it is retrospective data, and that needs to be validated prospectively going forward. So I would probably would recommend a patient to be on a clinical trial. Right. And if they fail to enroll in a clinical trial, we consider Gem-Doce followed by Pembro.
Great, thank you very much.
I think Dr. Williams had a question also.
Yes. Hey, Roger, nice seeing you. Anyway, great presentation. I think one of the things, as you know, a large body of my work is comparing costs. And given the CR rate, about 20% for some of these newer agents, not so new anymore, but definitely a new paradigm of which we're evaluating this, and the substantial costs that are associated with the CR, about 20%. I think these are things that we are currently investigating in my group, but need to have careful consideration as well as those toxicities that you mentioned. I know it wasn't or hasn't been largely studied, but presents itself as an excellent opportunity as all of our health systems now have increased financial strains, particularly given the global pandemic. But excellent talk, Roger.
Thank you so much. Yeah, I think financial toxicity is just as poignant as clinical toxicity and certainly needs to be considered going forward.
Thank you. Thank you, Dr. Stephen, and thank you, Dr. Rosalie, for that excellent talk. Before moving on to the next speaker, we have some interesting questions from the audience, and I would like to invite Dr. Raghavan to take the audience questions with the panelists. So,
hi, thank you so much. It was absolutely fantastic talks. So audience questions are coming in. One of the question, and I'm going to direct this to Professor Ginil, if Ginil is online. Ginil, is considering Indian patients are more commonly exposed to tuberculosis, can an immunological marker measurement like true culture be used to predict patients who may mount severe side effects to BCG? So do you have any technique to assess patients who would have a substantial side effects to BCG? Ginil?
Actually, the clinical side effects or dysuria, everything is studied as a marker for the BCG response. Apart from that, what are the markers we have is actually like fish and cyprate and all these things are not clinically, is very difficult to have it here in the community level. So probably what marker we have is the clinical response or the clinical side effects like dysuria, whether it will improve the outcome. So in our patients, whether they are having increased incidence of these side effects, we don't know. And there is no study based on any of the markers. A major factor is these markers are only separate is validated now. Otherwise, there is no proper markers we are having to assess the response at present.
Thank
Probably
you.
during that time only we can plan.
Can I direct the same question to Professor Roger Lee as well? Do we have any markers to assess the side effect profile of patients? Because BCG related side effects is a toxin problem, at least for the Indian patients that we deal with. So do we have any such markers to understand as which patient is going to have such side effects, in which case we can avoid and move on to a different type of treatment for them?
And that's an excellent question that's been, asked throughout the ages of BCG use. The short answer, I think, is no. I'm not aware of any biomarkers that can predict whether or not a patient is going to have intolerable side effects from BCG. In practice too, oftentimes you have a patient who you come in, who you think will be able to tolerate, and the next thing you know, they can't, even undergo the induction course. And something that I've noticed personally in my clinical practice is that, as you go on to give patients more instillations, they tend to start to develop more and more of these side effects for some reason. And it would be interesting to see if there's any genetic components that are or host factors that may contribute to this. But very important question to answer going forward.
Thank you so much, sirs. There is another BCG question coming, but before that, I'm going to direct a question to Dr. Vineet. You have already touched upon the importance of the first TRBT, and Professor Salam from Bangladesh has also mentioned the same. So for the sake of audience, could you reiterate the importance of the first TRBT that we do? It may be looking like a PG question, but one cannot emphasize the importance of that first TRBT, which is going to make a hell of a heaven difference to the patient's overall management for the next 15, 20 years to come.
Okay, so, I think it's not enough if we reiterate it, but I'll come back and tell you the same thing which I tell all my postgraduates. The M, remember all the M's. When you go in for a TRBT, make sure that you map the bladder first correctly. Make sure that you're methodical in your inspection, white light, NBI. Preferably use a 30-degree and a 70-degree lens. You have to be mindful of the fact that there could be abnormal vasculature. Pay attention to that because you may be getting a CIS. Make sure that you inspect the prostatic urethra well. Try and make sure that there's no bleeding. Get the muscle in your specimen, whether you need to do a cold cut biopsy or you need to ensure that, and of course, make sure that if you're using bipolar, try not to go too deep because you can cause an obturator reflex. Again, the laser there has a slightly bigger advantage. If you think it's an incomplete resection, make that in your notes, make it a mark to come back and re-inspect. Re-inspection is mandatory. And another small thing which a lot of people tend not to do is mark that specimen and send it off. So primary TRBT is the factor for everything else.
Thank you so much, sir. I mean, that cannot be re-emphasized any number of times, any number of meetings. That will be the same take-home message. I really appreciate that. A question that is coming to Professor Stephen. It's a long question, but primarily what's happening is that somebody got an SPC put in, and 4 months later, they are found to have a super large bladder tumor as well, and multiple tumors. The question that the viewer is asking is that if will the SPC insertion make a difference in the way we see the whole picture now? The patient still has an SPC.
Yeah, I mean, it presents an interesting circumstance, and aside from the underlying rationale to place the suprapubic tube in the beginning, I think, you know, it would not necessarily alter, at least in my eyes, the management of the tumor. I think we need to try to remove the suprapubic tube as soon as possible safely, as well as ensure adequate drainage, making sure no urethral stricture. And then once we obtain additional clinical information, the pathology, I would lend towards, you know, treating it as a de novo, and also at the hindsight, taking the fact that there's obviously maybe intraperitoneal concerns or whatnot at a later course, but I don't think we need to do anything irrational, you know, at this particular step.
Thank you, sir, because this is another, you know, very famous question that is asked commonly to the postgraduates, as well as to, it's a common clinical practice. An SPC is done in the community, and suddenly we find that they have bladder tumor, and then we have a stage migration, we have peritoneal concerns, and so on and so forth. So as you rightly said, think twice before putting SPCs. If it is possible to get a urethral access, that will be the best thing, at least for the time being, before you are very sure that the bladder is clean. I really appreciate that answer. Last question that is coming towards the BCG team. Question 1 and 2 here from Professor Salam from Bangladesh. Flu virus is effective in BCG refractory disease. Is there a role of flu virus and its relation to BCG refractory disease? And secondly, how is the effect of COVID-19 infection, patients who had COVID-19 infection, and their effect on the bladder cancer? Any takes?
So
open question. Anybody can take this.
I'll go ahead and take the first one. So I think what this doctor is referring to is the Coxsackie virus, which has been tested actually in the non-muscle invasive bladder cancer setting, not particularly in the BCG unresponsive setting. So in this study, it was a very small study that came out of the UK, where actually before resection, they instituted the Coxsackie virus infusions intravesically, and then resected the tumor afterwards, and saw that there was some efficacy to using the Coxsackie virus. Whether or not this is going to be borne out in the BCG unresponsive setting per se, it still needs to be, remains to be seen.
You're muted.
Sorry. And the other question that is there, how is the COVID-19 and the bladder cancer? Are we getting any, you know, first-hand information on that?
I'll kind of give you a take from Florida.
Okay, okay, go on.
Well, famous now for kind of the hotbed of COVID-19 since June.
Okay.
So, you know, here in Florida, I have not seen any decrease in our number of bladder cancer patients, and I think that's speaks to the amount of urgency that you know, community urologists and other physicians have for this disease. You know, so as a tertiary referral center, we get most of our patients referred in from outside urologists. And, you know, the one case that I'll tell you we're not seeing a decrease in doing is radical cystectomies as well as TURs. So even in the COVID pandemic, we've instituted a number of, you know, new measures in order to mitigate the effects of the virus. One of which is actually testing all of our preoperative patients for COVID within a 48-hour period prior to their surgical procedures. Even though you can imagine how much of a logistical nightmare this may become, but I do find that has, you know, completely eliminated the number of cases that we've seen in our cancer center, at least. And being that we are a cancer center, we're a sanctuary from you know, just your run-of-the-mill COVID-19 patients showing up at the doorsteps. I think that also helped in terms of, you know, protecting our patients from COVID-19.
Thank you so much, the international faculty. Tushar, you can take over from me back again.
Thank
and
you
thanks for the audience for those questions as well.
Thank you very much, Dr. Raghavan. We'll move on with the third speaker of the session. Our third speaker for the session is Dr. Murugesan Manoharan. He is a professor and chairman, Department of Urology, Miami Cancer Institute, Baptist Health, South Florida from USA. He was supposed to talk on early cystectomy for non-muscle invasive bladder cancer, selection, technique, and outcomes. But he has some engagements and unfortunately he cannot join us. So he sent us his recorded presentation and I'll be sharing that presentation with you all. Is my screen visible to all?
Good evening, everyone. Today, I'm going to talk about early cystectomy for high-risk non-muscle invasive bladder cancer. This is not going to be a debate, more of me sharing my thoughts on some of the data with you. I have no disclosures. What do we mean by early cystectomy? Are we implying that we are performing the cystectomy for bladder cancer too soon when it's not really needed? When you look at 3 different surgeries in urological oncology, for example, when you do a radical prostatectomy for a T1 disease, we don't call that early. When you do a nephrectomy for T1, we don't call that as a early nephrectomy. But for a lethal bladder cancer, when you do a cystectomy, we call them early cystectomy. So when you look at the different procedures, for T1 disease, we do only radical cystectomy in 10% of the patients, whereas for the prostate and the nephrectomy, we do it for 85% and 75% of the patients. But if you look at the outcome, 55% of the patients with bladder cancer only survive at 5 years, whereas in prostate, 95% survive and 85% of the radical nephrectomies survive. And still, for bladder cancer, we call that as an early cystectomy. So the term early cystectomy, we actually mean a timely cystectomy or choosing an optimal timing to perform a cystectomy without compromising the outcome for the patient. For scientific purposes and for manuscript purposes, we use 3 different terms. Immediate cystectomy means doing a cystectomy immediately after the diagnosis. Early cystectomy or a timely cystectomy means performing a cystectomy when the disease is T1 disease or done within 2 years of diagnosis. A delayed cystectomy usually means a cystectomy done 2 years after diagnosis or when the disease is T2 and above. If you look at the current worldwide data, at first year of diagnosis for T1 or a superficial or a non-muscle invasive bladder cancer, only 4.7% of the patients undergo cystectomy. At 2 years, still only 10% undergo cystectomy. So majority of the patients currently are undergoing bladder preservation for high-risk non-muscle invasive bladder cancer at present. The multi-institutional study from Gontero and group studied 2,450 patients with non-muscle invasive bladder cancer. Out of the 509 patients who underwent radical cystectomy for high-risk non-muscle invasive cancer, 113 patients, or about 25% of patients, died from bladder cancer. That is significant. And several other multi-institutional studies have shown that at 4 years, more than 33% of the patients died following radical cystectomy due to bladder cancer. Why are we avoiding early cystectomy? Mainly because of quality of life concerns with regards to urinary diversion, sexual dysfunction, and body image. We all agree it's a major complex surgery and it is associated with high complication rates. But when you are avoiding early cystectomy, what are the issues? We do not know who will respond to intravesical therapy. We do not know who will progress, who will have micrometastasis and die from the disease. Why is it important? The answer to the question lies in the outcome and the survival. When you look at the disease-specific survival for T1 disease at 5 years, is more than 90%. For T2, it decreases to 75. For T3, it goes to 50. And for T4, it is about 25%. To simplify it, you divide them as a non-muscle invasive cancer and muscle invasive cancer. If you offer cystectomy early on, the survival rate is 90%, whereas for the other group, it is only 50%. So there is a 40% difference between these two groups at 5 years. Moreover, when you offer early cystectomy, there are several benefits. One, as I mentioned, there is a greater opportunity to cure. You can identify patients who are understaged. More importantly, you can identify patients with lymph node involvement so that you can offer them appropriate adjuvant treatment. The early cystectomy obviates the need for regular cystoscopies and intravesical therapies, and after cystectomy, you can simplify the follow-up and it's easier to manage the patients. Let's look at the early cystectomy for high-grade T1 disease. There is no level 1 evidence to suggest optimal treatment for high-grade T1 disease. Most of us, including myself, depend on expert opinion, personal opinions, how we interpret the data, and also how we consider the quality of life is important for a particular person. T1 high-grade disease is biologically aggressive. We should not treat that as a superficial cancer or a low-grade cancer. Why is it important? Because high-grade T1 disease has got an increased propensity for recurrence, progression, metastasis, and death. The recurrence rate can be between 60 to 80%, and progression rate is 30 to 50%. On patients who undergo immediate radical cystectomy following T1 high-grade disease, up to 20% of people die from bladder cancer, which is significant. Another important question is, are we really dealing with T1 disease when we say it's a T1? When there is no muscle in the specimen, understaging can be 50 to 70%. When there is a muscle in the specimen, even then, understaging can be 25 to 30%. More importantly, there will be inter-observer variability among the pathologists with discordance rate of up to 50%. More importantly, do we know whether the T1 disease patients got lymph node positivity or not? We assume no, but studies have shown that even in T1 high-grade disease, 6 to 16% of patients do have lymph node involvement, and these patients can be denied yearly adjuvant therapy like chemotherapy and immunotherapy, and we risk death in these patients. What is critical is to do a good repeat TUR to minimize understaging. But what happens when you do a repeat TUR? We can have 4 different scenarios. If you have a T2 disease, you're going to offer them radical cystectomy, radiation, or chemotherapy. If you have a T0 or a CAS on repeat TUR, the rate of progression is almost 20% at 5 years. But most importantly, if you have a T1 disease on re-TUR residual disease, the progression rate is 80% at 5 years. This is one subset of groups you should really think about offering early cystectomy. Mayan group, they studied 230 patients, divided them into 3 groups: immediate cystectomy following non-muscle invasive bladder cancer, cystectomy after BCG failure, cystectomy at progression to muscle invasion. And they looked into the disease, and in the group 1, where there's immediate cystectomy is offered, the progression-free survival is 77% compared to 51% and 49% in the other groups, with almost like a 27% in survival benefit. Another study from Memorial Sloan Kettering looked at 307 patients, out of which 90 patients underwent cystectomy. These patients had non-muscle invasive cancer. They divided them into early cystectomy, which is done within 2 years of diagnosis, and delayed cystectomy, where the cystectomy is done 2 years after diagnosis. In this group, early cystectomy patient, even after 15 years, the disease-specific survival is far superior. And similarly, non-muscle invasive group who underwent cystectomy before becoming muscle invasive is far superior with regards to survival at 15 years. To simplify that, if you have a non-muscle invasive disease, if you do an early cystectomy, the survival figures are 92%, whereas a late radical cystectomy was 56%. In recurrent muscle invasive disease, the early cystectomy, if you offer it, the survival is 41%. Even then, it's much better compared to the late radical cystectomy of 18%. What it means to you is that 2 factors are important in the outcome. 1, pathological state. Obviously, non-muscle invasive is better, but more importantly, the timing of radical cystectomy is important in survival at 5 years, 10 years, and 15 years. So when you choose the patient for early cystectomy, most of us agree that if the patient wants a cystectomy, if it's suitable, we are going to offer that. Other considerations are multiple tumors, large tumors bigger than 3 centimeters, associated carcinoma in situ, lymphovascular invasion, prostatic urethral involvement. Other regular factors we consider as inability to resect it completely, inaccessible tumors such as anterior tumor close to the bladder neck, diffuse carcinoma in situ, patients who cannot receive BCG or patient failed BCG, or patients have intractable symptoms. In a meta-analysis of a large group of patients, studies have shown that pathological features such as carcinoma in situ has got a hazard ratio suggesting early cystectomy is better is 2.4. For prostatic urethra, it's 3.59. For multifocality and sessile tumors is 1.7 and 1.9. For tumors bigger than 3 centimeters, hazard ratio is 3.12. But remember, for patients with T1 high grade and re-TUR, the hazard ratio is 6.9. And if you see a high grade tumor on first cystoscopy after BCG, it is 4.8. So if they have any one of these factors, you should consider offering them early cystectomy. And the studies have shown that if you have more than one factor positive, such as, for example, size bigger than 3 centimeters and carcinoma in situ, like 2 factors are positive, these are the patients who will really benefit from early cystectomy, and they should not provide them disservice by not offering them radical cystectomy. Other variant pathology, such as micropapillary features, nested variant, plasmacytoid, and sarcomatoid disease, they all have poor prognosis if you don't offer them early cystectomy. But the bladder preservation option should be offered to every patient. You should have a meaningful patient-physician discussion, probably in more than one sitting. Even now, intravesical BCG with induction maintenance BCG remains the single most effective therapy. However, the early cystectomy plays an important role in select group of patients. It is nicer to have some biomarkers and genomic markers to differentiate who will progress and who will not. But right now, we do not have any effective markers. Several studies are going on, but studies have shown that about 20% of the non-muscle invasive bladder cancers have gene signatures suggestive of muscle invasive features. Also, there are 6 different molecular subtypes have been identified, which can help us to identify who will progress, who will not progress. They have not made to the clinical use yet. Right now, a couple of markers are quite useful. For example, loss of CDK into A and B has seen in about 38 to 40% of patients who progress to muscle invasion, and absence of activating FGFR3 mutations may also indicate progression. Probably over the next few years, we might be able to see them in clinical use. Right now, we do not have any effective markers. So final thoughts on early cystectomy. The aim of the early cystectomy for non-muscle invasive bladder cancer is to prevent death from metastatic bladder cancer. So to me, it just makes sense in high-risk cases to perform cystectomy before rather than after stage migration and stage progression. The current philosophy appears to be the radical cystectomy is unnecessary in 30% of the people, whereas we are willing to lose the life of 20% of the patients by denying them radical cystectomy. The quality of life is important, but what is the most important factor affecting the quality of life? All of us know the life itself. If the patient is not alive, these things don't matter. So most important for us, the question we need to ask, and the question we should not ask, the question we should not be asking is cystectomy necessary yet? Instead, the question we should ask is, when is less than cystectomy sufficient for this patient to treat the bladder cancer? Thank you for your attention.
Thank you very much, Dr. Manoharan. The last 2 slides beautifully summed up. It's more important, the life is more important than the quality of life. I had a few questions for him, but we're short of time and he's not available online with us. I just have one question which I'll direct towards Dr. Sudhir Raval. So are you online?
Yes, Tushar.
Sir, I just had one question with you. The Indian practice in our scenario, what is the percentage of patients of non-muscle invasive bladder cancer, T1 high grade, the high risk patients, whom you offer upfront radical cystectomy?
Yeah, actually all the factors which Manoharan has said, those I definitely discuss with the patient that you will require, it is better you have cystectomy, but many of them may not agree, but we do offer. Another thing, that during the course of BCG to these treatment, if they are going BCG to these patients, and if they have the intractable symptoms of frequency dysuria and other things, there are only two reasons. One is either they have not responding to BCG or they are having BCG side effects. And if they are not responding, we do cytology and biopsy, then they go for early cystectomy. And if suppose their bladder becomes small or something, then we also offer them cystectomy, or depending on the type of diversion, they can be offered either neobladder or ileal conduit. One more comment I would like to make here. In the previous session, which Raghavan has asked for SPC having in a patient who has got a multiple bladder tumor. I am a, probably next senior most urologist after Dr. Pritish, rather uro-oncologist, and I have seen that era. Then we used to have patients coming from outside having SPC done, and there is a bladder tumor lurking. Our teaching is that once the SPC is done, it is T4 disease. And I didn't know in the beginning of my career this thing, and I actually closed the SPC after refashioning everything, did TURBT, and gave the patient BCG. After 1.5 years, he came with the inguinal node. So the treatment for them is cystectomy, because it's T4. Things might have changed, but we do not see nowadays SPC. I think last 5-10 years, I have not seen patients coming with SPC in a bladder, but other centers, a small city, they can have this kind of.
Sir, would you give chemotherapy also in these patients in a perioperative setting, because you're upstaging it to T4?
Yeah, we can do that. It's changing. Now we don't see, but we have seen this thing happening.
Just for the clarification on that question, so what percentage of your patients who have got NMIBC, high-grade NMIBC, you would offer them cystectomy, but what percentage would take? Because in England, anybody under 70, almost 70% would go for primary radical cystectomy, whereas here, even when we offer it, they don't seem to take it up.
Yeah, they are not very keen. Here, they are not very keen for surgery. But I think 20% of the patient, they can still, and sometimes I insist when there's a big tumor, multiple tumor, and CIS, and we nowadays do PET scan, because PET scan is there. Sometimes you see that hidden lymph node, already they have gone outside this thing. So fair number of the patient, they do agree, but I agree with you, it's not that very acceptable type of treatment to these patients.
Thank you.
Right, so just one last question before we move on to the next session about the taking forward from the SPC. What if there is an intraperitoneal perforation and the histopathology comes out to be a non-muscle invasive bladder cancer? How do you treat that, sir? Do you do upstage that too?
See, this thing was discussed. I have asked this in many UCCon to the many urologists, uro-oncologists, and I thought that this does upstage the tumor. And they should be having primary chemotherapy rather. And we do that thing. Many times we have done that thing, thinking that gets upstaged. But there was a trial in England only. There's a center, Dr. Nitin Kekri told me, that they treated these patients with intravesical chemotherapy only after giving a peritoneal lavage and closing the bladder, and they did not fail.
Right, sir. Thank you very much, sir. With that, we come to the end of this session and we move on to the next session, the third session. For the next session, I would like to invite my colleague and friend, Dr. Zishan Ahmed. He is an associate professor, Department of Urology, and the Chief of Innovations at Kasturba Medical College, Manipal. I welcome Dr. Zishan to moderate the third session and invite the speakers.
Thank you, Tushar. That was a quite informative session on BCG and early cystectomy. Dr. Manoharan has already given his opinion on early cystectomy and micropapillary variant, which may bias this session. But still, we have to move on to the attraction of today's webinar, which is the great debate, where we have two Mumbai Indians battling it out, early cystectomy for micropapillary urothelial carcinoma. A brief description of the case scenario. We have a 75-year gentleman with diabetes and hypertension with a history of smoking for 30 years who presented to the outpatient department with painless hematuria, no clots for 2 days. He had a fairly good performance score of 60. We did ultrasound and found a 3 centimeter papillary lesion in the left lateral wall of the bladder, and his upper urinary tract was normal. He was offered TURBT, where a 3 centimeter pedunculated papillary tumor was present without any CIS. Tumor was resected in piecemeal. Deep muscle biopsy was taken. The final histopathology came T1 high-grade micropapillary variant of urothelial carcinoma. Muscle was seen but not involved, and there was no lymphovascular invasion. PET CT scan was done, which showed no metastasis, and the final diagnosis here is a PT1N0M0 micropapillary urothelial carcinoma. We have Dr. Yuvraja, Chief of Robotic Surgery from Kokilaben Dhirubhai Ambani Hospital, Mumbai, whose area of interest include robotic surgeries in uro-oncology, mainly prostate cancer and bladder cancer. He will be defending early cystectomy for a PT1N0M0 micropapillary variant for urothelial carcinoma. On the other hand, we have Dr. Gagan Prakash, who's a good friend of mine, professor of uro-oncology from Tata Hospital, Mumbai, with keen interest in bladder cancer and rare tumors of genitourinary tract. He is also the governing council of Global Society of Rare Genitourinary Tumors. He will be speaking against early cystectomy. I know it's a tough game here. The case is quite interesting and management can be both ways. I'm sure at the end of this debate, we'll have clarity on management of small micropapillary bladder tumors. May I now request Dr. Yuvraja to share his presentation and start the debate.
Yeah, you are.
Yes, sir.
Can you see the screen, Jason?
Yes, sir. And you're audible too.
Okay. Thank you, Jason. And thank you, the organizing committee, for giving this opportunity. I think my life, as Jason told, has made very easy by Manoharan. I thought that that would have been the debate rather than me talking about it. So it is just an extension of what Murugesh has told. I think I have Gagan Prakash, who is my friend, and I think he'll be defending whatever he wanted to do it. And let me see what we have to learn with this debate. And even this was a new learning for me, because usually these are all rare tumors and we hardly read about it. So now Jason has wisely put a different question altogether. He added few things yesterday only. So we were preparing for a different scenario altogether. So two things, the main changes are also lymphovascular emboli, which is very common in this tumor. The second is generally these are all not a pedunculated tumors, they are broad-based tumors. So these are the two changes that have been made for the debate. Fine, let us see. So now when we say this is a rare tumor and how do we manage these tumors, we have something in our mind. What is that is going on in our mind? So one is that, so do we prepare, are all the pathologists are prepared to diagnose this condition? First of all, the answer is well established. It's quite easy to diagnose these tumors. Second is that, so he has given a timeline of deadline of 75 years of age. So then the people think that it is really dangerous to do surgery at this stage? No. The answer is no. Is diabetes hypertension scary for us? No. All of the patients, so above 50 years of age, majority of them are all diabetic and hypertension. We don't care about it. Is mortality or morbidity high with surgery? Marginally. You can say just because of the old age, not because of cancer. Acceptable. Is survival different from TCC versus micropapillary? Absolutely yes. So normal urothelial carcinoma versus a micropapillary variant, huge change. Is radical cystectomy preferred initial treatment? I feel it is yes. I think that is the end of our debate. So everything is answered. So let us see. So when these patients choose, do we have to do radical cystectomy in a minimally invasive way? Can we do it? Absolutely yes. It has been done even in octogenarian. So I think we have all the points, and again, Gagan will be defending his own views on this. I feel so. This is the word to go. So, as Murugesh told, this micropapillary variety. So we know that it is true for all T1 high-grade tumors, but it is understage very often. So that is 50 to 60%. Recurrence is very high, 30 to 70%. Disease mortality is very high, so 30 to 40% even in superficial. Quality of life cystectomy, acceptable. One-time investment of cystectomy rather than undergoing repeated, cystoscopies, TURBTs. No recurrent TURs and scopies. Disease survival and overall survival superior to radical cystectomy, proved by many literature. So disadvantage is there is an invasive procedure. So let us see how we can have all these things in the literature. So I will request all of you, and including Gagan, to look beyond what we think. So it is not that easy that we just have a diagnosis and treat it. And what is causing the damage in the body? We have to think all those things. So looking at histology, it's quite uncommon. So around 1 to 2% of our TCC are all micropapillary variant. So if you see this picture, how to diagnose? So on the right side of this picture, so this is the normal TCC papillary. This is micropapillary. This is one slide tell both of them. So it's quite easy to diagnose. More common in males, more common in older age. So that means in the older age of micropapillary where they're going for surgery. Present with advanced stage. So rarely we see a T1, but in many of them are all T2 and above. High incidence of progression from non-muscle invasive to muscle invasive. That means all the bad prognostic factor where as a surgeon we don't want them, it has. And it is associated with urothelial carcinoma. Mind you that it is not only a pure, so it usually is associated with other urothelial carcinoma. And important is that even percentage of micropapilla is important. Let us see later on. Lymphovascular embolization, very important. Most important is very common in micropapillary variant. Associated CS, again, quite common. That means as we know that any high-grade feature, if it has got one or two or more features, so I don't think we can be offering the patient. So whether the patient chooses it or not, it's up to them. But as doctors or as a clinician, it's our duty to do that. So this has been explained earlier. So any patient who has got a high risk factors, which is the right side of the slide. So any variant histology for that matter, including micropapillary, is a very high risk category. In according to AUA criteria, for this patient, we should be offering an invasive procedure. So let us see. So this is a literature. So this is just a presentation about literature review. So the first question we had was, this is more than 75 is it quite safe to do? Absolutely. There is no absolute contraindication to do, not to do a surgery or a radical cystectomy more than 75 years. We have got many literature for this. Next is that not only for micropapillary, for any other T1 high-grade tumors, you can see that with or without PLND, so the survival is better when we do an invasive procedure. We have proof for that. This is one of the article from Carl Etulle, so that you can see that this is how we get the results. And then the lot of work has been done by none other than Dr. Ashish Kamath from MD Anderson, starting from 2006. There are 4 or 5 papers, and he's very expert in this. If you see this very old paper of Journal Urology 2006, intravesical BCG therapy is ineffective. First point, BCG is ineffective in micropapillary. Then what to give? So we don't have any other agent to offer them, these patients. And in micropapillary urothelial carcinoma, radical cystectomy performed before progression is going to affect survival. This is the conclusion in 2006, not now. So it's almost 2 decades old now. Again, another paper in 2007. So they updated the result, and if you can see, you can see that 5-year cancer-specific survival is only 60%, when compared to cystectomy, it is 82%. So the conclusion was it has got a very poor prognostic factor, micropapillary cancer. And then we have again from the same group of MD Anderson 2015, intravesical BCG has got higher rates of recurrence and progression. Unbelievable. So we don't have any other intravesical therapy to take care of this type of cancer. And then upfront cystectomy, 100% disease-free survival of follow-up of 72 months, longer follow-up. So we, what else we can have? And I think it is a very aggressive disease where it requires an aggressive treatment. And then we have a SEER database published this year, this month. So that says, stating that micropapillary is ineffective, chemotherapy is ineffective in this type of histopathology, but no benefit effect in organ confined stage. However, in metastatic stage, there is some benefit. That means we don't have any adjuvant treatment for this. So that means before going, the disease goes into the muscle, so we should remove the bladder. That is the take-home message. Again, we have a multi-institutional study published in last year in urological seminars. So if it says that if you do a cystectomy with a urothelial carcinoma versus micropapillary variety, so there is a huge difference in survival. That means we should not wait till the cystectomy is being done for a muscle invasive tumor. No, not at all. Again, we have another literature for micropapillary variety, the percentage of MPC component. If you see these two pictures, recurrence as well as death is very high. If it is more than 50% of micropapillary structure, that means that also we should look into that. On cystectomy, MPC component is upstage to 79% in non-muscle invasive MPC. Remember that. That means, so there is a, even the component or the percentage of tissue is MPC increases when we do cystectomy. So that means, so in aggressive, we are missing, we are just seeing the tip of the iceberg, and is lot of things inside the body. SEER result database. Again, there is a opinion from SUO member, Society of Uro-Oncology members. So although most favors early cystectomy for MPBC, so that, this is a take-home message. This is published in 2014. And there is a meta-analysis, although it says little equivocal about cystectomy, but if you see the cancer-specific survival, cystectomy is 81% versus 60% in TURBT. So that means there is a huge difference in survival. Although, the only difference is that the treatments are little different because we are going to preserve and remove the bladder. For that particular patient, it may be a difficult thing to choose. Micropapillary bladder cancer, again, if you see this research report, the Gagan may quote this report saying that cystectomy did not show a survival benefit, but he should read in between the lines. The percentage of the patients were only 33 patients in a huge database, national cancer database. So it causes a very small sample size to say that it's causing a sampling bias to come to a conclusion. So forget about all this literature. So now we have AUA as well as NCCN guidelines where they take into account all the published trials. This is the recent certification guideline. If you see a high-risk tumor, T1 LVA plus or minus variant, there is no other option given here. It's only cystectomy. There is no option of intravesical therapy given it here. Then what else we are looking into that? So now the upstage is 50%. That means we are missing 50% of the patients. We are doing only a conservative line of treatment, and we are doing injustice to these patients. High risk of progression. It is not clear whether intravesical therapy works. And, the excellent oncological outcome despite morbidity associated with cystectomy is acceptable. That's what the guideline says. If you see a EAU guidelines 2020, any variant histology of urothelial carcinoma with or without whatever, lymphovascular embolization, radical cystectomy should be considered. So in this refuse, then you can give BCG or whatever you want. If you see the diagram below, so this is how the survival decreases with increasing the cystectomy time. It's actually, they call it as not early cystectomy, they call it as immediate cystectomy. Immediate means at the time of diagnosis of micropapillary. So if it is early cystectomy, after a course of BCG. Late cystectomy, salvage, means after multiple intravesical therapy. The survival decreases with delaying cystectomy. NCCN guidelines, variant histology, aggressive therapy in the form of radical cystectomy. I think beyond these things, there is no doubt, according to me. So Gagan, please don't look into don't try to catch the tail. So that is means doing TURBT or intravesical therapy. So we have to catch the elephant here. So that is going to be harm. So do the cystectomy. So thank you so much, and all the best, Gagan.
Thank you, Dr. Yuvaraja, for an excellent presentation, reviewing relevant literature and discussing immediate cystectomy for micropapillary variant. I'm reinforcing the word immediate cystectomy. We know you have reinforced the need for early cystectomy, and you're nearing as a clear winner, but still the stakes are pretty high here. Let us hear what Dr. Gagan has to offer to his patient. Over to you, Dr. Gagan Prakash.
Thank you, Dr. Yuvraj. Thank you, Zishan. My slides are seen.
Yes.
Yeah, so I would be speaking against the motion that cystectomy need not be or should not be done in this patient. Conflict of interest? No, but this debate is definitely about a conflict in a matter of our interest. Disclosures, this is my first debate ever on a forum. And interestingly, this debate is against somebody who's been a mentor to me always. So when I first heard about the scenario, which was, as Dr. Yuvraj mentioned, information was initially 75-year-old male, diabetic hypertensive, T1 disease, high-grade micropapillary. I must mention that after getting that scenario, I haven't Googled so much about a talk ever since, And I was wondering that both Dr. Raghavan and Dr. Gagan, my namesake, they're good friends of mine. Now, what happened? And then I had to find a better friend in Zishan who got some more details into the scenario. And these details were that this patient had a Karnofsky performance score of 60. The tumor was a pedunculated, clearly pedunculated 3 centimeter tumors, no CIS and no LVI. And obviously there was a sigh of relief there. So clearly, I think Raja sir has decided that this patient has to undergo a cystectomy. And what's lying on the table is micropapillary. I'm not sure if the patient is there. It's definitely micropapillary. There's a lot about micropapillary here. So our patient is a 75-year-old gentleman who had diabetes and hypertension. I'm not sure which of the following does the patient look like. Apologies to Mr. Bachchan. I'm a big fan of him, but I think this really closely relates to the class of patients that Dr. Yuvraj treats. So now, morbidity and mortality related to cystectomy is there. It's a matter of concern. And let's talk about some good evidence over here. So this is a systematic review from the European Urology, and they've emphasized on 3 particular points for doing cystectomy in elderly patients. Number 1, a geriatric assessment is must and should be done. It improves the outcome. Second, elderly patients have inferior survival. And third, elderly patients have an increased perioperative mortality. And this is a systematic review. So if you look at this, the black boxes are where the outcomes or the complications are more. And clearly the 90-day mortality, we have more than almost 5 studies which says that the 90-day mortality are more in elderly compared to younger patients. Now, I would like to ask if for this patient has any kind of frailty index on any kind of geriatric assessment done. The G8, which is the most popular, or the F1 frailty index, or the John Hopkins calculator, has any of these been done for this patient? Diabetes. So, let's look, when we look at the comorbidities, you'll be surprised to know that from a large series of 1,000 patients, diabetes was the strongest predictor of late complications after cystectomy. There's more to this. Another study, which again found the same thing, that diabetes was significantly associated with severe complications, Clavin Endo 3, 4, and 5 complications in patients undergoing cystectomy. Now, other considerations. Did this patient undergo a restaging TURBT? Did the patient have LVI, CIS? So yeah, we know that he did not have LVI or CIS. What was the percentage of micropapillary tumor that this patient had? And was the micropapillary superficial or invasive? There's more details to it. So as Dr. Yuvraj mentioned, I should be reading between the lines. Let's try and do that. A study from 2 of the most prominent GU pathology names, Dr. Amin and Dr. Epstein, which is on a series of micropapillary cases. And the conclusion mentions that some cases of non-invasive micropapillary urothelial carcinoma are not necessarily associated with an adverse outcome. Another study which actually hits the bullseye: is immediate radical cystectomy necessary for all patients with non-muscle invasive micropapillary bladder cancer? It says no, particularly once you start looking at whether the subset is a superficial micropapillary or invasive micropapillary. So clearly the survival as well as the recurrences were different for a superficial versus an invasive component of micropapillary. These are the charts, these are the figures. You can clearly see, how wide the charts are when it comes to superficial versus invasive micropapillary, LVI versus no LVI, and T1 versus T2 micropapillary. Percentage of micropapillary. Conclusion: in the absence of associated carcinoma in situ, which was not there in our patient, intravesical BCG treatment may be offered when the micropapillary component, the carcinoma component, is a small percentage. Unfortunately, we don't have the percentage in our patient. Another series on the same kind of patients that we have, the T1 micropapillary, by none other than Harry Herr and Victor Reuter. And the conclusion was that certain patients in whom T1 micropapillary urothelial carcinoma was managed conservatively did not have significantly worse outcomes than patients treated with early radical cystectomy. SEER database. Dr. Yuvraj did mention about this study. Now, this SEER database study is probably the largest series of micropapillary, where around 519 micropapillaries are compared with 150,000 conventional urothelial cancers. Now, what's happening over here you see, so, we are never likely to have a randomized control trial for a, rare cancer like this. But next in line comes a propensity score matching. So what's happening over here is there was clearly a difference in the survival outcomes between the micropapillary and non-variant ones. But when a propensity score matching was done, the outcome difference greatly diluted to the extent that the overall mortality on a propensity score matching adjusted analysis was the same or not significant in the two groups. A good editorial from Dr. Kamath. Does variant histology change management in non-muscle invasive bladder cancer? I know he's a big proponent about doing early cystectomy in these variant histologies, but do also mention that within these variant histologies also there's a lot of heterogeneity, and it's important to pick up those the tumors which may not be that aggressive. Also, let's realize that there might be various occasions when the micropapillary has not been picked up and we have treated these patients, as non-muscle invasive. Is radical cystectomy let's consider, okay, this was micropapillary tumor, this was a variant histology, this was an aggressive tumor. But even then, is radical cystectomy the only option for definitive management of micropapillary tumor? In today's date, no. So last month's published tetramodality treatment for variant histology, where they've combined a maximal TURBT along with chemotherapy, radiotherapy, and partial cystectomy, and the 5-year cancer-specific survival are almost the same at 82%. So, other than cystectomy or radical cystectomy, other options can also be considered. Another series which talks about partial cystectomy in micropapillary tumors. I think in the future, there's more and more evidence, particularly from translational research, that micropapillary is an immunogenic tumor, and probably there would be a role of immunotherapy over here, and the management is likely to be biomarker based. Just a series. This was a poster presented from our pathology department in the European Congress of Pathology a couple of years back, but to highlight that from a span of 2007 to 2016, there were only 22 patients of micropapillary which was seen in Tata Memorial Hospital, which would be probably around 35 by now. And with those kind of numbers over so many years and a smaller proportion of them having NMIBC, are we strong enough to say that we should just do cystectomy for all these patients, especially when they're elderly and frail? Thank you so much.
Thank you, Dr. Gagan, for the comprehensive presentation. We must applaud the effort put by Dr. Gagan defending alternative modality for micropapillary bladder cancer. I know you were put in a tough spot.
Modality.
Sorry?
Tetramodality cancer.
Tetramodality, the new word, yeah. I know you were put in a tough spot, but you emerged stronger with tetramodality for this patient. Most of the doubts are answered by both the panelists. I have a few questions in mind, keeping in view the residents and young urologists. So, as Dr. Gagan mentioned, does the treatment plan change if it is focal or extensive micropapillary tumor? What you would like to say about this? And the other one is when you mentioned superficial micropapillary and invasive micropapillary, did you mean it was muscle invasive, or it's a different?
These are the subsets of a T1.
Yeah.
So within T1, we can have a superficial as well as invasive. They're like, if you go to the pathology journals, there's a lot of articles from pathology journals of micropapillary, and they talk about the types of different micropapillaries. It's just that, because the proportion of micropapillaries in NMIBCs seen is so less that, the information about it and the standardization about it has not happened.
Yeah. So if it was a focal micropapillary tumor
or superficial, I don't think there's a terminology like focal, but yeah, probably superficial micropapillary is being
okay.
Given, yeah.
There are some articles in which they say if it's less than 25%, they consider it as a focal, and then if it is extensively involved, they call it extensive micropapillary.
5%, less than 5% is focal.
Yeah, less than 5%. Okay, so another question, sir. What is the role of molecular biomarkers and subtyping in micropapillary urothelial carcinoma? There's one article in which they say if it is P53 positive, then it's more aggressive.
So basically, typically the NMIBCs have the molecular subtype, the popular ones are the basal and the luminal ones actually. And the luminal one is the one which is the more aggressive one. And what's been found with micropapillary is that most of them are luminal. So most of them are probably the aggressive ones. And, P53 and other biomarkers are being seen. I think even the pure study, which was typically about use of immunotherapies in variant histology, is something I'm not sure of the proportion of patients in the pure study which had micropapillary and compared to the other variant histologies of urothelial cancer, but probably it shows that there is room for immunotherapy or upcoming role for immunotherapy as well in variant histology. So one of the things over here is that a lot of these patients who die is because of a systemic failure. Even if you do cystectomy, even then they may not have a very bad outcome. So I think the bigger need is about kind of finding a solution for systemic treatment for these patients, and the local treatment, whether it should be radical cystectomy or partial cystectomy or radiotherapy, is the other set of question which needs to be ordered.
Yeah, and I have a question to Dr. Yuvraj. Do we need to get a second look at the TURBT specimen by another pathologist to avoid any inter-observer variability before embarking on radical cystectomy?
Yeah, of course. If you have any doubt in your mind and if it is not matching with your clinical features, so I think it's better to take a second opinion, unless you have got a good pathologist who can be confidently telling about all these things. I think it's a very good idea always. It's like taking a second opinion for surgery.
And Dr. Gagan, would you counsel the patient regarding the need for radical cystectomy at a later date?
I think let's talk about, once the debate is formally over.
All right. So let's declare the debate formally over. Yeah. But before we do that, I think I'm going to put Zishan in a spot. I mean, he can't get away so easily because he's the moderator, the chairperson, and the judge all rolled into one. So he's the boss of the debate. So Zishan, who do you think won the debate?
Both are quite close to me. I mean, Dr. Gagan's been my senior, and Dr. Yuvraj has recently placed me in robotics.
No, I think Gagan, you are right. Even Zishan is right. So because when the case, when you give a case scenario like this, is only 1 or 2 points are covered. If you have to take it in a bigger way, bigger vision, you have to have multiple features to come to a conclusion. So having said that, once there is a micropapillary or any variant histology for that matter, if the adeno or squamous cell carcinoma, we have to be very careful. Choose patients among this into 2 groups, whether they require cystectomy, and offer them. That's all what I can say. So you have, we know what are the other histopathological features which can give aggressive, like percentage of the tumor, whether it is deep inside or whether it's a lymphovascular emboli. Everything we have to consider, not one point. That's what I feel.
So I must thank, both Dr. Raghavan and Dr. Gagan for choosing this because, in terms of yield, I think there was a lot of knowledge gained while, reading for this.
Yeah. I think Zishan has made sure that when he comes to Mumbai, he gets to, have a party with both of you by not committing on who won the debate. So hats off to your diplomacy, Zishan. Over to you.
Yeah, and thanks for letting me have my first debate ever,
I think you're going to have a lot more, Gagan, by the way things went today.
Thank you.
Can we move to the next presentation?
Thank you.
Now I request Dr. Sanjay Adla, who is a consultant uro-oncologist at Apollo Cancer Institute, Hyderabad, to commence the next session. Thank you.
Good evening, everyone. I'm going to request Dr. Professor Anish Srivastava sir to give us a talk summarizing how TURBT has evolved over the last 3 decades. That's almost the lifespan of quite a few people who are listening to this talk. So let's see what he has learned so that we can start off from 31st year. Thank you very much, sir. Anish, sir, you can start off.
So, good evening, everyone, and thanks SOGO and Sanjay and Gagan for the opportunity. So, what I am going to talk about in next 12 minutes is basically the 2 things where my journey has been with the 2 issues all along. So, one is this, and then I'll have a brief mention about my journey with the intravesical BCG and the Indian scenario. This talk is going to be confined to the basics, and we have heard a lot, and this will be a complementary talk to Dr. Ginil and Dr. Vineet Kohar, who have given us the best kind of scenario and the most recent advances. So this is an overview of practices for the conventional TURBT. I'm not going to touch anything about the en bloc and things because most of us still need to learn a good conventional TURBT. We all know about these techniques. There has been ample number of times a debate between which is better, whether it is bipolar or monopolar. And we all, as good urologists, as teachers, we teach everyone to take all these precautions like low power settings, decreased bladder filling and stuff like that. Lasers are not very easily available across the board. I mean, if we talk on the Indian scenario, and still, despite all these precautions, the obturator spasm, which is a nightmare to especially the young urologist, it happens. So before we go further, these are the techniques which I said you can do as a urologist. But what you can do to modify the practice along with your anesthetist. So we need to learn about the course of the obturator nerve. At the neuromuscular junction, it causes the release of acetylcholine, and that is where the kick happens. So we all know in short about the spinal and epidural alone. It's a lot dependent upon the kind of fibers which are blocked first, last, and the jerks do happen and perforations do occur. Other techniques are along with the obturator block. Again, this is a review of literature that it depends not only on the expertise but on the variations in the anatomy of the nerve, where even the best kind of anesthetist, even with ultrasound guidance and all the blocks, can have a problem. So then we need to learn about what happens in general anesthesia. So basically, in short, we have the non-depolarizers and we have depolarizing agent, which is succinylcholine, the only agent. And the non-depolarizers, which most of us are using. And the issue is that if you are using a non-depolarizer and if there is a current or touch, your loop touches the area in the nerve, then there is sudden acetylcholine release, and the non-depolarizer, which is in blood circulation, may not be enough. And therefore, still, despite that, the jerk might happen. And if you give them more of these things, the non-depolarizers, as I said earlier, then there are issues. Still, there may be a problem. So that is where the succinylcholine, it can be given along with the endotracheal intubation and muscle paralysis, the non-depolarizers as well as depolarizers. So I'm going to say about the approach which I have been using, that is without endotracheal intubation and giving succinylcholine when you are nearing a tumor in the posterior lateral wall. Believe me, you can do most of the QRBTs without that, without giving any kind of muscle relaxing agent, just with the LMA, which is very safe and it has 100% efficacy and safety. Back about in 1993, the first time when I gave this along with my anesthetist, this was being done with the regional anesthesia, and therefore the practice was not accepted by the anesthetist because there were issues. But now, after the LMA, that is the general anesthesia without endotracheal intubation, things have changed. If you see the recent review from our friend Nikhil from Hertfordshire, England, who has been working on this with the two anesthetists, all the techniques have been reviewed. Succinylcholine has been used by others as well. But what I am trying to say, is something very different. You might say that what is this old man ultimately trying to teach us? Reminds me of Ernest Hemingway's novel, The Old Man and the Sea, where Santiago, the protagonist, was not able to catch a large fish even in 2 days. Friends, what I am trying to say that with this approach, I am not even allowing the anesthetist to intubate. So there are no issues of throat discomfort and whatever morbidity. I'm not allowing them to give any kind of the non-depolarizing agents which require reversal and a late recovery. I am giving you 100% efficiency. As I said, it works for 10 minutes. And you can get a good muscle. See, with reducing the morbidity, we have all been talking all along, like getting a good sample, the first URBT. So this is what you are going to achieve. And I have had some presentations and publications with now still working more on this. With this, I would say that let me go to the another one. So we have talked enough this evening about the issue. My only point is to take you along the journey in India, and these are the issues which we all need to. We all have actually addressed with the previous experienced speakers, very nicely covered. But this is what remains the holy grail: the dose and the clinical schedule balanced against the efficacy and the toxicity. So this is our first study from SGPGI way back in 2002, where we assessed interleukin-8 with the Danish strain. As we all know that most of us are working only with this, which was being prepared in Guinea, but somehow it was not available for quite some time in between. And then the another strain is the oncotice, which most of us are giving. So our studies are based on that. And here, what we saw was that IL-8 response to low and standard dose BCG was similar. And the mean was higher in responders than in non-responders. Continuing the same, again, we published another study in 2006. And this was where the 80 milligram was pitched in with all these same parameters and IL-8 as the immunological marker. And now in India, most of us have been practicing ever since either 80 milligram or 120 milligram based on the study which we have done. So then there were a bit of deviation here. We studied the gene and all. So probably there are a lot of things studied in this area. Couple of other studies from Madhu Agrawal from Agra. So they studied, but then they used 1997 classification. They did not use any marker. Had the same conclusion as ours. From Dr. Rajiv Sood and all, recently published in 2020 itself. But they used the EORTC 2006 criteria and no markers. There are a couple of other studies from Dr. Mohanty, the pioneer, one of the pioneers in this area, and from Chandigarh. My point is that in India, we do need to, really look forward, because whatever we have done, and then of course, I should not forget the work from Jinil and Dr. Jinil and all. There may be some more which I may not have been able to find on the literature review. We are all working, but we need to look now with the molecular biology of the disease well known to us, the signaling pathways better understood, the classifications which have changed, and the risk stratification which we all have been going through this evening. So the issue is whether we should start afresh or we go along with the tide and then see our own resources. Now you see the low grade and high grade, the pathways are different. Everything has become different. I need not go back into the whatever has already been said, but this is the time. Should we go for a cytokine or two, which we have been doing and are happy with, or take a big panel, what Ashish recommends, needs validation? Are the biologies really different? The authors from West are also claiming that even very low doses are also equally effective. So then, because that was the premise earlier, that we in Indians being immunized with BCG as a child, do we really need high doses? But then, if you look at the literature from the West, they also say the same. So there is a lot to ponder. Should we be looking at other risk factors, other things nicely covered this evening? So finally, friends, I would say that there's a lot to ponder, miles to go. In Indian situation, we need to have actually, a kind of our own registry, multi-center studies. We should join together, and then I think we will come to some solution. Thank you very much.
Thank you very much, sir. That summarized on 27 years of journey just from your publications. We'll try to highlight a few points of what you have raised in a CBD. So I'm going to start off. Thank you very much. I'm just going to start off with the sharing my screen. Okay, you can all see it. We'll start off. Okay, so this is the faculty, but because you can all hear me, isn't it? But because of a few people dropping off, all of you need to be concentrating because I'm going to be asking few questions intermittently, especially Gagan with a G.
Gagan is always with a G.
The second somebody always spoken of with respect, Gagan Ji. Okay. So, Raghunath, SK Raghunath, Rakesh Sharma and Jiten Jaipuria are the new people who are going to start off. And then we have already heard from Vinay and Manohar and so who are not around. So all the speakers are on the panel. So we'll start off with I am surprised that nobody has covered this part. So I'll just start off. It's a real patient of mine, 50-year-old female patient, irritative lower inner tract symptoms, bloods and investigations done, and the ultrasound scan showed 2 by 1 centimeter right lateral wall. I'm going to request for some specific answers, and we are starting at 8:25, and I have been given 20 minutes to try to come to use the information that we have gained. Okay, Rakesh, would you consider doing a urine cytology, and why would you do it?
Yeah, urine
what additional
cytology.
information is that giving you?
Urine cytology basically to see whether we are dealing with a high-grade lesion or there is a possibility of a CIS in such patients. So to rule out those things, cytology would be helpful, and CT urogram, because before going for a TURBT, you have some information on the grade of the lesion. So that's why I would like to do a urine cytology. And it's quite a cheap and readily available investigation, so can be done at most of the centers.
Okay. For me, the main issue with respect to the cytology is the quality of the people reporting on it. That's one. Yeah. The second is the next step is going to be TURBT anyway, and it is going to tell me whether I have got a high-grade tumor or not.
So basically now, see, it's a standard test now. Most of the pathologists are well aware of doing a urine cytology, and I feel it is available in every center. There is a good pathologist or uropathologist to give answer on a hematuria is never a problem nowadays. Cytologists are able to do that in a bloody urine also. They are able to get the malignant cells. Yeah.
Convenience element of it, you are doing it. Okay.
Yeah.
Would you do a CT urogram at this stage, or would you like to do a TURBT and then do a CT urogram?
I would do a CT or a CT urogram, whatever you call, whatever is available. A CT urogram would do the job for me. Here, basically, to rule out, because ultrasound, I believe it's very much a individual base. So many times you can have problems with the ultrasound.
No, I wasn't comparing with ultrasound. I was saying, why are you doing it? What additional information are you looking for?
I won't get an additional investigation. In a real life scenario, probably I won't do a CT scan with a 2 centimeter bladder lesion. 3 centimeters generally I keep the cutoff for my patients. And if there is no hydronephrosis or anything on ultrasound scan, I might avoid a CT scan. But and 2 centimeter lesion having a muscle invasive is also not very common, but you can see everything possible. So doing a CT scan is not difficult in our country. So I would recommend a CT scan also.
Okay. And you would do it before TURBT?
I would do before TURBT.
Okay. For me, the answer was yes, I would do a CT scan in a young patient. I would like to know a baseline. That's one. The bladder staging would be better before a TURBT rather than after a TURBT. Yes.
Agreed, sir.
SK Raghunath, MRI scan and a PET CT scan. You can answer the second one and then come to the first one. Would you do a PET CT scan? I'm not saying in a 2 centimeter. Let's leave this one. In a bladder cancer, do you use the PET, and where would you use a PET?
Sanjay, generally, with the diagnosis of a 2 centimeter or 3 centimeter tumor, generally I would not jump into PET CT scan. I would consider when a large tumor is there with extravesical extension, which is seen on other imaging like MR, CT, or even an ultrasound, large extravesical growth is there with hydronephrosis or some lymph nodes are there. In such cases, probably I may consider PET CT. Otherwise, generally, I don't recommend PET CT in clinical practice.
So in your normal in your normal day-to-day practice of staging of a urothelial carcinoma, you don't use a PET CT scan unless there was an unusual thing. Yeah, agree with that?
Yes, okay. Yes. Maybe after muscle invasive disease is confirmed or on CT or MRI, if it is showing extravesical disease, in such cases, probably I may consider PET CT. Otherwise, at the time of diagnosis or before TURBT, I may not consider these cases.
What additional information would that give you? Your MRI scan is saying that there is extravesical disease. There might be lymph nodes there. What additional information would that give you? PET CT scan?
Risk of having metastasis is relatively more whenever you have extravesical disease and whenever you have lymph nodal disease. So
I'll do the other way around. So you're saying that by doing a PET CT scan, the chances of you picking up metastatic disease are higher compared to doing a CT chest and a contrast enhanced CT abdomen pelvis.
Yeah.
Okay.
I agree with you, Sanjay. And the cost is also almost similar, same for PET CT.
So I wasn't talking about the cost element of it. So you would do it for staging purposes for all locally advanced bladder cancers.
Yes.
Any evidence backing for that?
There is no evidence, but we pick up even non-lung mets. Sometimes, very rarely, we have seen, the bone mets with this, though it's very rare. So that can be picked up on PET CT, which will be otherwise missed in CT abdomen and CT chest, but this is very rare.
Okay. So, and MRI scan, do you think it's going to soon replace the CT for local staging of the
Yes. Okay. Definitely, I think so, because MRI wire-rad scoring is coming up in a big way. Probably it's going to, replace CT urogram, but it is very early to say that. The validation has to take place, and it has not percolated down to the common practice. So it is still practiced in few centers. Probably in the years to come, probably will be considering MRI instead of CT urogram.
Sir, I have a point. MRI is okay for local staging, but for upper urinary tract, which may have tumor in a higher percentage of cases, depending on where the tumor is in the bladder, CT urogram still scores over MRI. So that may still have a role despite MRI.
Just going, thank you, Jitan. I was just going, but the PET CT scan is not discussed. I know the Western guidelines are different to ours, but I thought at least they would mention a bit in case if that was going to be the standard of care in the near future. That's one. And regarding the cytology, use voided urine cytology as an adjunct to cystoscopy to detect high-grade tumor, which is what Rakesh has said. I just wanted to pick Sudhir Raval's sir, do you use PET CT scan in the initial? Let's forget this 2 centimeter. Let's look at what Raghunath sir has said. In that there is a locally advanced bladder. Do you use PET CT? What additional information would that give you?
Sanjay, I always use PET CT, and I learned this in a hard way when one of my patients who had muscle invasive disease, on which I did bone scan and CT abdomen and X-ray chest, and I operated. He came after 1 month with paraparesis, not realizing that he had the bone mets. So after that, there's, I think, article that urothelial tumor, they are best detected as far as metastasis is concerned is by PET CT.
Okay.
So it's not for local, it's for mets in the lung, liver, bone somewhere, or retroperitoneal bone.
So for metastatic staging of urothelial carcinoma of the bladder, standard of investigation in Rajiv Gandhi is a PET CT scan.
Yes.
Okay.
And then it helps in further, when the treatment is given, chemo and all, you can really follow whether his patient is responding or not.
So your initial staging assessment is based on a PET CT scan, and the follow-up response is also based on a PET CT scan. Okay. It's just that I understand why we are doing it, but I just feel that we are totally an outlier with respect to the amount of usage of PET in India compared to anywhere else. I just wanted to know your practice.
You are correct, but not for the such tumor, right? As you said, it's locally advanced or this thing, not for these tumors.
Okay, so this.
I think to add to the point that Jiten was making correctly, I think if you look at the NCCN guidelines for a follow-up of patients who have undergone a cystectomy, you can do a PET CT scan, and that's a category 2B recommendation if you are suspecting a metastatic disease. But the standard of follow-up would actually be a CCT abdomen and chest with CT urogram. But because PET CT is not considered a valid way to look at the upper tract recurrences. And one of the things that you want to look at in the next 2 years after a cystectomy is that if the patient is getting a recurrence in the upper tract, for which PET CT is not a good idea. So I used to follow up patients after cystectomy with PET CT. But when I read these guidelines, a little bit with more intensity, I moved back to a CCT abdomen and chest with CT urogram to pick up the upper tract recurrences as well. So that is one thing that I think Jiten had already mentioned. That.
Yes, I agree with you.
Okay, so this is what we saw on the bladder. So this was quite a large volume of intravesical tumor. Okay, I just asked Jiten this specific question. Yes.
Yes, we do diagnostics.
I was asking was, I don't know if it makes, so all of us or quite a few of us do a rigid cystoscopy with a 16 or 18 French cystoscope, then take it out and then put in a resectoscope to do a resection. Is that necessary step?
I think so, yes, sir, because the view with the 16 French scope is wider, with the cystoscope sheath and scope is wider, and we mark all those lesions there, because with a narrow view with a resectoscope and a loop in front of you, you tend to get a myopic view. And then, so this mapping of bladder is, I think, better. Other thing is, when you want to use more wider degree lenses, like 70 degree, you put it in a resectoscope sheath, you are looking at the floor of that metal. So that is not good. So if you want to look with wider angles, again, you need a cystoscopic sheath only. So I think it is a good step to do a diagnostic cystoscopy, get a wider view, be more clear, and then you go ahead and do your resectoscopy.
Thank you. It has given an answer. The next one would be, what size scope do you use for the initial cystoscope?
Yes, a 30 degree scope with a 20 French sheath.
20 French sheath. Okay. And these are the, I'm just going to ask, would you use monopolar and bipolar? Why, Raghu?
Yeah, probably bipolar. If it is bipolar, it's available, it's better. Less charring, and probably even the obturator jack would be less.
Okay. Would anyone use laser for that? Even if it was available, the thulium fiber laser was available for that cystoscopic finding. Vinith is not there, but I think that would be difficult one to resect with that. En bloc or piecemeal, we would like to do it en bloc, but I think it will end up being, all of us would say that it's a piecemeal.
Yes.
Spinal versus GA?
GA is preferable. GA if we can have.
Okay. Irrigate or not irrigate after the resection?
Yeah, irrigate.
Whenever large tumor is there, I always irrigate.
And why are you doing it? Are you doing it for the hemostatic purpose or as a decreasing the tumor recurrence?
Decreasing the tumor recurrence, some for to prevent clot formation.
Okay. So
to prevent clot retention.
Okay. Jiten, you've instructed your registrar or anybody to do your TURBT for this one. What all information will you be checking when you come back and see on the resectoscope?
Yes, so I always tell them to start with examination under anesthesia first. People tend to miss it. But with a larger tumor, it is still valid today. So there was this good study from MD Anderson where they saw that examination under anesthesia findings were as good as radiology in predicting T3 or T4 disease. So if you are able to feel the bladder mass under anesthesia, you are probably looking at T3. And if the mass is fixed, that is T4, and that is as good as a CT scan finding.
What all you do is evidence-based. So just tell me what all you do. Then we'll go.
Yes, so we have a standard data capture thing with all our TURBTs. You're mentioning the size, the number of lesions, what is their appearance and morphology, whether they are, sessile or with a stalk and pedunculated. Do they look muscle invasive? So there is another thing. The appearance of a tumor assessed by a surgeon is as good as even MRI, when you're talking about muscle invasive or frankly non-muscle invasive tumor. So the appearance, what he feels, whether there are any other patchy areas which are abnormal, and whether you have resected it completely, how was the bladder otherwise, what about the orifices and about the urethra, and whether you encountered any complaints. I think that list completes it there.
So all the things that are there on this are minimum data set that everybody who is doing it.
And we also encourage a bladder diagram where you have this is as per EAU.
Okay. So all these are, I just want to pick on, why is bladder capacity important?
So bladder capacity, it can help you decide. Suppose, for example, you have got a small capacity bladder, then you are less keen on keeping it. And associated diverticular, all these things have to be seen.
Okay. So in case if they were going for bladder preservation or anything with radiotherapy or BCG, then it will give you a better idea.
Yeah.
Okay. So when would you give mitomycin?
So immediate post-op is best. Some people give it right on table. In my residency, I gave it right after resection. But anytime within 6 hours is then the next second best thing, and anytime within 24 hours is the minimum that you need. So that
as soon as possible is when you would like to give.
Yes.
Okay. That's good. Thank you. What to give? Anybody wants to take this?
So whatever the data suggests, they all are equivalent, Sanjay, but epiresicin definitely scores better than others. And in India, most of us use mitomycin C. There are a few people who are using gemcitabine, but the most common is the MMC, I believe, and well tolerated, as you have mentioned. And the studies are also maximum on MMC, and efficacy was also little better compared to, but there is no significance on that.
Earlier, I used to not irrigate, but since these evidences started coming in that irrigation does tend to help, I give the intravesical mitomycin and then I tend to irrigate them just for the added effect. Whether there is any added effect, I don't know, but I just feel that you might as well just do it. Yes. So mitomycin as quickly as possible, I tend to give it on the table.
Yes.
And all of them are equal. When not to give?
So basically, an obvious bladder perforation you have encountered during the surgery, avoid giving this because there can be systemic absorption and related side effects. Then if there is obvious bleeding, you have resected, but still there is a dark urine is coming, you want to wait for some time, avoid. Ideally, go back and stop the bleeder, but if you want to wait with irrigation, you can, but try to give within 6 hours once the bleeding has stopped. Third is if you have done deep resection, you can see a fat, avoid because there can be systemic absorption. And one more thing is incomplete resection, Sanjay. And if as per the EUA guidelines, it says that if the URT series score is more than 5 and if you have more recurrences in the past 1 year, so there is not much of benefit in those patients.
I wanted to just specifically ask regarding complete resection.
Yeah.
We have done an incomplete resection and we know that mitomycin can be cytotoxic. So I want to treat that as well with mitomycin. If I don't have a bleeding, what am I losing by giving mitomycin? Incomplete resection, I got hemostasis. I've done my 1 hour of resection. I want to come on another day. What's the problem in giving mitomycin?
So it all depends. Probably if you are going to do a 2-stage TURBT, then it's not going to benefit because the tumor might still be bleeding and you want to irrigate it rather than give the MMC and wait for 1 hour. Because again, there will be a clot formation. It can be a problematic for you. If you're going to do a 2-stage TURBT for a large volume, probably a TA type of lesion. So there won't be any point in giving. You can give after the second resection, probably if you have done a complete resection.
What I was trying, because there is some evidence to say that if there were small papillary lesions, if you give them mitomycin, it will annihilate them. But whenever there is a gross residual tumor, mitomycin might not do the job. So
no, incomplete resection means, Sanjay, I meant to say there's a large tumor left behind. And probably either you are going to treat it by some other modality of treatment like a radical cystectomy or a radiation therapy, whatever is your choice of treatment at that point of time, or probably you're going to do a second TURBT. Second stage TURBT.
There is even data if you give BCG without tumor present in a person who doesn't want TURBT, tumors have gone away. That is also there.
Those are very small lesions actually, probably less than a 0.5 or 1 centimeter lesion.
Yes, I've given out the answer. I just wanted to know how many of these we all do. Like, Raghu, do you want to take us through that? How to give it? How to optimize the mitomycin? Yeah.
Yes, Sanjay, you're absolutely right with all these points. Earlier, we used to give 50 ml of normal saline 40 mg of mitomycin. Now we've reduced to around 20-25 ml. We don't alkalize the urine by giving these tablets. We add the soda bicarb to normal saline. So that itself will increase the pH. And we always make sure they should hold the dwell time should be 2 hours. To help the patient to hold for 2 hours, we reduce the irrigation. If we stop the irrigation and we tell them to not to take too much of fluids, we stop IV fluids. And if any residual urine is there, always we empty the bladder. Then you go for the mitomycin.
So for me, I have changed since I've started reading more about it. I've increased the concentration to 40 milligrams in 20 ml. And I give them bicarbonate the night before. On the night before, on the day of the surgery, they have it so that we are alkalinizing whatever is coming through in the urine as well. To what extent, we don't know, but that's what I tend to do. But probably what you're doing of adding bicarbonate to the mitomycin, probably that's even more effective as well.
So one more thing, if we have done recent TURBT, try to empty all air from the bladder. Otherwise, to the dome, it won't go. Okay. When you are emptying the bladder.
So histology, it was an incomplete resection. I marked it there. It was a 10 by 6 centimeter, overall 50 grams resected, and it comes as low-grade urothelial carcinoma without laminal. So this is previously G2TA or low-grade TA. Yes, muscle in the specimen is there, clear of any tumor. What would you do?
Sir, since it is
among this, what would you do?
Sir, since it is an incomplete resection and the pathology is not adverse as such, I would go for re-resection because there is no survival advantage to other options like radical cystectomy. I don't think so, sir.
Okay.
It is not an early radical cystectomy case. It is still TA, low grade. We should go ahead and re-resect.
What would you? So I went for re-resection. Okay. This one, now I do a re-resection. Let's say that we do a TURBT, small complete resection, you give mitomycin. Then the patient has a recurrence at 6 months. You do a re-resection. Do you again give mitomycin, Raghu?
Yes, Sanjay. After resection, I give, but probably I may not continue mitomycin. I mean, this is intermediate risk disease.
No. Okay, so I wasn't asking about this. So every time you resect a bladder tumor, which is complete, which is low grade, you give mitomycin.
See, you don't know whether it's low grade or not.
Yes.
After TURBT, it will take 2 to 3 days for the report. So I don't know whether what is the histology. So always after TURBT, when I suspect I'm resecting a tumor, always I give.
So though the evidence is only for giving the initial resection mitomycin, we extrapolate it to say that we give it every time you do a re-resection.
Every time. Yeah.
Gagan, any comments on it? Gaganji?
I think we don't have any evidence to say one way or the other for this particular clinical situation. But, broadly speaking, you can make out on the basis of a cystoscopic evaluation whether the disease is low grade or whether it's high grade, and whether and you can correlate it with the urine cytology.
The question was mainly, when you think it is a low grade, do you give mitomycin after?
Yes. So you should, but in this particular case, when you are re-resecting and you will probably be giving mitomycin over the long term or the maintenance. I'm not really sure, but I think I would err towards giving it versus not giving it in this particular case. I agree with Raghu, and Raghu is my friend, so I have to agree with him.
Sir, another thing is in low grade, actually, adjuvant mitomycin immediately given, the risk of recurrence is lowered less. If the disease is high grade, the probability of lowering the recurrence rate is even better by giving mitomycin. If you look at the data, 45 to 46% is like what you can reduce by if you go to the high grade subset. If you are in a low grade subset, the advantage of adjuvant mitomycin in preventing recurrence is actually quite low. So the higher grade, the better.
For adjuvant mitomycin.
Yes. But then this was in the era when the BCG was not given as common. These are old trials. But since the mechanism of action is unique, here you are trying to prevent tumor cells from reimplanting into bladder, which doesn't happen later. I think it is valid to give mitomycin.
Okay. Jiten, you're saying about a single installation, or you're talking about
single adjuvant? I'm talking about immediate Immediate one. Yeah.
Okay, so this one again was a bit of a, so where would you put the patient into? So here, if you say multiple, recurrent, large, G1, G2, TA, yes, but the key is all the features must be present. I was surprised that though we think it is an intermediate one, whenever there is a recurrence, they fall into high risk. Multiple, recurrent, large, G1, G2, TA, low grade tumors, all features must be present, comes under high risk.
So this was not a recurrent case here. This was an
This isn't a
incomplete.
recurrence, but when it comes at 6 months and it falls into that category, I used to put them into the intermediate risk.
Yes, sir.
I used to put them into intermediate, but when I was reading for this, actually it should be in the high risk. Gagan, agree with that?
Completely. I think all of us have learned while preparing for this webinar.
I thought they would fall into this, but when I was reading this in clarity, yes, all of them should. So the only feature that is not present is recurrent, but the others are the multiple, large, G1, G2, TA. Yes. Okay. So I gave them all the options, intravesical mitomycin, though intravesical. Would you consider him for BCG, Raghu?
Definitely, I would consider him for BCG because multiple tumors are there. So he will fall into intermediate risk as it is not a case of recurrence. I would go with BCG in this case.
Okay. So would you offer him radical cystectomy or she's a 50-year-old?
Probably I would not at this point of time because it is low grade. I would try with BCG. If it works, it's good. Okay. If it recurs after BCG, then probably we can consider.
The patient had 6 weeks of mitomycin following which monthly MMC for 12 months and that kept control. I was surprised that it worked, but she said, I'll go with the least complication one and that's what I tried and it worked. Okay.
Sanjay, even mitomycin, even after BCG failure has been tried, it works in 30%.
So probably she fell into that 30%.
Yeah.
So Sanjay, what about this, because in the EAU guidelines and all the other guidelines, it's not really mentioned, the schedule of intravesical chemotherapy for intermediate risk is not really mentioned. So whether giving that monthly additional maintenance dose of chemotherapy is any better than just giving 6 doses at induction. What are your comments on that?
All the ones that have studied are with 6 months of induction, 6 weeks of induction and monthly maintenance. There isn't any study to say that comparison of them. And these are intermediate stroke high risk. So you're frightened of just giving the 6 weeks of induction. So that's why to keep you happy and the patient happy, I think giving monthly maintenance keeps it a bit under control and you feel that you're keeping an eye on the patient. So
do you always give maintenance for all intermediate risk, or would you also just consider 6 weeks of induction mitomycin and stop for some patients?
I always give 6 weeks of induction, and whenever induction has worked, maintenance of monthly. Whether it's not that very good evidence base, but extrapolating from BCG. Okay, so my time is 25 minutes. I'm 5 minutes over. I have got 2 other scenarios, but we have to end there just because of the paucity of time. Thank you very much for your contribution. Hopefully, we learned a bit.
Sanjay, before we wrap up, let me have the honor of thanking you for being an absolute rock star moderator for the case-based discussion, like you always are. And having you on the panel really gives us the confidence that the case-based discussion will be one top highlight of the entire event. So thank you so much for putting in all the effort and organizing everything. And of course, you and your panelists have done a fantastic job with this.
Thank you.
Sir, I want to just share one slide with your permission. Gagan, sir.
Please.
This is regarding the next SOGO meeting, which we are doing on the 18th of, it is 1810. I'm sorry for that. It's 1810, that's 18th of October. The SOGO meeting on muscle invasive bladder cancer, and we have 2 star people. Dr. Rajesh Kruti is a professor and chair at UCSF Department of Urology, and Hassan Abol Anin, professor of urology at Mansoura University, Mansoura. So I would request, I've still not shared the program details with all the star faculty and other people of the national faculty basically. So in the near time, I might share all the details of the program and give the invitation to all. But this is like a program blocker for the day.
Thank you so much, Rajesh.
Thank you very much for permitting me, sir.
I think this is going to be one amazing webinar on 18th of October.
18th of October, yeah.
Perfect.
So, Gagan, can I say something?
Yes, sir, ma'am. I was going to invite you.
Exactly.
For
that is
it. Sir, people of your eminence should not be saying anything without getting invited.
Because you guys are keep on talking. You are not.
All right. So may I have the honor of inviting Dr. Raman to wind up the program and give his
thanks, Gagan. And first of all, I thank you and Raghavan to make a great program, which kept almost 86% of the audience stick to the program. They did not leave. Today's attendance, almost 86% people did not leave. Otherwise, what is happening in the webinar, a lot of people will come and then after one or two talk, everybody will leave or there will be only 50, 60. So this is the data from the webinar organizer. And next thank to Dr. Stephen and Rosalie. They are still with us and that's great to have, and hopefully make a good friend and see you in person, all of you. And then I thank Tushar and Sanjay. Raghu is anyway, he's one of the organizer in this thing. Dhunil is part of the SOGO, Dr. Anish. And the Rakesh has already shared this event, which we have already taken the commitment from Raj Bruti and Hassan. So hope to see you on 18th of October. Till that time, stay safe and take care of yourself and your family. Thank you. Good night. Bye bye. Morning.
Thank you very much, sir.
Thank you. Thank you so much, sir. Thank you so much.
Thank you, sir. Thank you, sir.
And thank you so much to the international faculty and the national faculty for putting up such a great show. Thank you so very much.